we'll go back. Thanks, everyone. I'm super happy to be here. I always jump at the chance to speak to my own peers and inspire all of us to continue the pursuit of excellence in nursing and midwifery. Today, I'm going to share how our role as fertility nurses and midwives has been further solidified through ESHRA's work and how certification contributes to global recognition, job satisfaction, career progression, and raising the bar for high-quality fertility care. This is not going to be a super heavy research kind of talk. Hopefully we keep it a little bit light and fun, inspire you all to think a little bit differently about what your role is, what it can be, where it can lead you. So without further waiting, before we can focus on where we are now, where we're going, we need to also pay homage to where it started. And one person in particular I'd like to highlight, and that's Jean Marion Purdy, the unsung hero and someone I didn't even know existed until about 10 years into my so far 17-year career. Jean Purdy was not only the first IVF nurse, but also the very first embryologist. And she co-founded the first IVF center, the Bourne Hall Clinic. There's a new Netflix film, Joy. It's getting a lot of buzz, particularly. One thing that's been really nice to see is that Jean is front and center. Joy tells the story of the first IVF. So maybe now you all know about her, but I didn't. So she worked in the physiology lab on tissue rejection after kidney transplantation, and she was actually recruited by Robert Edwards to work on a special project treating infertility. She regularly traveled with him, where they brought gynecologist Patrick Steptoe on board. He was a pioneer in laparoscopy for gynecology. This is how they were able to retrieve an egg. And after nearly 10 years of work, Louise Brown was finally born, the first successful live birth after IVF in 1978. Here on this slide, you see a picture of her pointing to Jean's name. So it was Jean, really, who ran the first IVF lab, an 8x8 box, windowless, I've heard. She cultured cells in a Bell vacuum jar, which was warmed in an incubator because gassed incubators did not exist yet. She ordered lab supplies, prepared culture medium, helped to monitor gametes and embryos, and recorded data. Nursing prepared her for sterile techniques and gave her the important knowledge base in reproductive medicine, physiology, anatomy. Embryology as a profession didn't exist yet. And of course, it was also Jean who coordinated and counseled the patients. Again, her nursing background equipped her well here. And then when the program switched to a single oocyte recovery in natural cycles, she got up in the night, whenever, to collect urine from the participants and testing it for LH surges with one of the very first immunoassays. Again, a nurse is used to a task of this type. Jean was co-author on 26 academic papers about IVF between 1970 and 1985, including those published in Nature and The Lancet. However, for years, she was barely mentioned, and even I, an IVF nurse, a passionate one, didn't know about her until 2017, when it was actually Helen who explained who she was. Edwards and Steptoe gained almost all the recognition, and it took decades for her contributions to be recognized publicly, but now she's front and center in a Netflix film. Plaques have been changed, including her name. And even Edwards said on the 20th anniversary of clinical IVF that there were 3 original pioneers in IVF, not just 2. So I say this, I want you to remember this as you journey through your own fertility nursing career. I want you to know your contributions. I want you to know your worth. I want you to be unafraid and to be willing. Okay, so let's fast forward some years. Edwards co-establishes ESHRA with Dr. Jean Cohen in 1985, and already in 1987, there's a paramedical group of which nurses and midwives are a part of. ESHRA continues to play a crucial role in establishing standards and developing roles, most notably through professional certifications. First, the embryology one, then came nursing and midwifery. Now there's fellowships and centers can get certified. But we're here to talk about the nurses and midwives. The very first nurses and midwives certification exam was held in 2015. And I'd also like to mention the special interest group for nurses and midwives, because in 2018, the paramedical group was actually dissolved and nurses and midwives got their own special interest group, further solidifying and defining the unique clinical role that we nurses and midwives have. And by the way, you can thank our chair, Helen Kendrew, for both of these developments. So why do this? Why do this certification? Why have a special interest group? Now, let's remember that ESHRA is a European society, and in 1993, the European Union was established. It brought together people and professionals, healthcare professionals, with different language backgrounds, different credentials, different degrees in training, and different roles, and of course, different care models. And in 2005, there was an EU directive called the Professional Qualifications Directive that established principal requirements for nurse and midwife education, but member nations still maintained their own domestic authority. The formation of the EU created free-flowing workforces, which is great, moving across borders, so that workers are going where they're needed. But training and education of professionals like nurses and midwives continued to vary and still does today. While the process of professionalizing and standardizing nursing globally through bachelor requirements was and continues to be underway, the answer in the immediate term to solving this problem of a free flow of workers across borders has been to turn away from a system of trying to harmonize the education systems where everyone's doing the same, and instead going to a system of recognition where we just accept each other's education systems. This means that countries in the EU need to accept the diplomas and credentials of nurses from other countries with different education requirements than their own domestic ones. So the free flow of much needed nursing manpower in Europe is as much a strength as it is now also a challenge. Meanwhile, the nursing workforce is aging. People leave the profession. Burnout is a real thing. Population at large is aging. Fertility rates are declining. And by the way, we're also in a global full-on global nursing crisis. So even though we're here as fertility nurses and midwives, we're still fundamentally nurses and midwives, and therefore we play a part in this global nursing shortage, and it's only forecast to get worse. The European Commission estimates a shortage of nearly 1 million health workers in the future, in the not so distant future. So why is this important? Well, we need to keep the nurses we already have in the profession, and we need to inspire new ones, especially when the profession at hand is also so crucial in addressing the declining fertility rates observed as a whole. This is why job satisfaction and career progression is so important, not only on a personal level for us, but on a macroeconomic level too. This graph here is a population pyramid. The younger ages are at the bottom of the graph. Older ages up at 85 years old is at the top. The solid bars is the population in the EU in 2019, and the outlined bars are the forecasts. So if you look at this, you'll see that in the future, by 2050, we'll have fewer young people, fewer working age people, and more old people. So in the future, will there be enough of us? And of course, this graph also ironically explains how much work we have as fertility specialists. This slide illustrates a little bit more of what I was talking about the flow of healthcare workers. It's a little bit older. It's from 2017. It's from Politico. And it charts healthcare spending against doctor-nurse migration. So the blue areas in the map are areas that spend a lot on healthcare and welcome new healthcare workers. And the red areas spend little on healthcare and they watch doctors and nurses walk away. This is pre-Brexit, but this is a proper challenge that we continue to face. So if our training and education differs and our compensation maybe differs, it is no surprise then that the role differs just as much. And if the role differs, then naturally the model of care will differ too. Some of us might just have certificates from 20, 30, 40 years ago. Now we're more of a bachelor model. Not all countries are on board, even within the EU. Quite a few of us are going for master's degrees. Even more so lately, we see people going for doctorates. Some of us might have subspecialty training. We might have credentials. We might be nurses, or we might be midwives. We might be both. We might be assisting procedures. We might be performing them, like ultrasound, insemination. Some midwives are doing embryo transfers. Some of us have prescription writing privileges. We might be working in settings that are more nurse-led or medically led. Our salaries probably vary quite a bit. And then, are we compensated for our extra competency? If we do continuing education, if we go for that master's, are we seeing it reflected in our salaries? Another issue to address is the lack of a clinical practice guideline specific for fertility nurses and midwives. If you do a PubMed search, you're not going to find very much. If you check the ESHRA website, there's no clinical guideline for nurses and midwives there. ASRM, nope. So there's no currently published clinical practice guideline for fertility nurses and midwives. Hopefully I inspire some of you to help start a project like that. But without guidance, without guidelines to set benchmarks, is it possible to ensure consistent high quality care across Europe or globally? So if we put all this together, then how do we define ourselves? Standardize ourselves. And without standardizing ourselves and setting benchmarks, is it possible to ensure that all patients get the highest quality of care consistently, no matter where they are? Now, I will posit that ESHRA certification can help fill that gap. But granted, it's not a requirement, and it's relatively new. It only started in 2015. I just want to take a quick moment here to point out that we use a lot of terms interchangeably. We might call ourselves IVF nurses. We might call ourselves fertility nurses, infertility nurses. We might be working in MAR or ART. We use these terms interchangeably. I do. And that also actually kind of highlights my point about what are we? Okay. So more specifically about the ESHRA certification, nurses and midwives working in the field of human-assisted reproduction have broad and increasing responsibilities. And so the ESHRA certification is unique. It provides and offers a formal recognition for nurses and midwives with a specialist interest in reproductive health. The certification process defines competencies and requirements for professional practice and covers the different fertility nursing and midwifery roles, which aim to increase the quality of healthcare by establishing criteria for high professional standards. I'm happy to say that we've summarized the history of the certification, how it came to be in an article that's freely available online. It came out this summer, so I encourage you all to take a peek. Many of us gain expertise while working in clinical practice, and given the success of the embryologist certification program, which was implemented in 2008, the Executive Committee of ESHRA assembled the Nurses and Midwives Certification Committee in 2012. They were tasked with developing a certification program specific for nurses and midwives working in reproductive medicine. Identifying a starting point for developing the certification program proved challenging because there's no clinical practice guidelines. And while the American Society of Reproductive Medicine, ASRM, began offering a nurse certificate course in 2010, it didn't have a logbook. It was online modules only, and there was no official invigilated proctored examination of knowledge. So the NMCC, as it's called, the Nurses and Midwives Certification Committee, decided to gather background information by systematically reviewing the literature, consulting and surveying a larger expert panel of international nurses and midwives, and surveying Belgian and Dutch nurses and midwives working in different types of settings. And it's all boiled down to this pathway. This is very much an oversimplification, but it gets the point across. You apply online using a platform that was created and run by ESHRA, available on the ESHRA website. You complete a logbook, and you have 2 years to complete the logbook. You write an ethical case, you submit it all through this platform, you study, and you pass the exam, hopefully. The logbook, I took a screen capture of what the certification platform looks like so that you can conceptualize how you fill it out. For each task, you fill in the date, whether you assisted, observed, or performed the particular task, and then there's a place for your supervisor to co-sign. They're subdivided into 8 categories. As of this year, there are 73 different tasks, and if some task is not offered in your country or setting, you can give a presentation to your colleagues and upload the PowerPoint from the presentation. The curriculum is broken down into 14 sections, and the reading list is connected to this in the curriculum. Includes guideline documents from ESHRA, important consensus documents like the KPIs, key performance indicators for the lab and clinical settings, the guideline for add-ons, guidelines for repeated pregnancy loss. It establishes fundamental competencies, but may serve to introduce the learner to new and advanced concepts in the fertility care setting, like these guidelines for fertility preservation and routine evidence-based psychosocial care. And of course, it's heavy on the epidemiology. It includes research curriculums, so stuff that you might not be doing day-to-day in the clinic, in your day-to-day FaceTime with patients, but is important, essential knowledge. The exam is online. During the pandemic, COVID, we could no longer have an in-person exam, and it went so well that it's now only online, which makes it so much more accessible for us on a global stage. There are live invigilators. You download a software. The software monitors that you don't have other windows open. It's a really properly locked online exam where you can't cheat. There's 100 questions. You have 2 hours. These are a couple of sample questions. I'm not going to go through too much of that right now, but just know that there's a mini mock exam on the ESHRA website as well to get an idea of what types of questions they ask. I'm more interested in sharing what the impact is with you guys today. ESHRA recognized the need to articulate the different tasks and roles of nurses and midwives working in reproductive medicine in particular, the education and training required to enhance and develop quality standards in clinical practice. Interestingly, the whole development of this ESHRA certification program has established an advanced curriculum for nurses and midwives and continues to function as a central body, creating and maintaining minimum standards in both theory and clinical practice, regardless of origin or geographical location. We're now undertaking a 5-year follow-up survey of nurses and midwives that obtained certification, so we're hoping to share those results soon. I'm going to share one small little anecdotal unpublished survey that I've been working on in Norway, which included 56 nurses and midwives working in infertility. Almost a quarter were already certified, which is great. 67% were interested in ESHRA certification, and 76% wished that they had an advanced fertility nursing credential, something that it officially recognized from a legal perspective as well, their specialty. So what's the impact? Well, we've observed some things anecdotally that we hope to evaluate empirically. These things include that the candidates become familiar with many gold standard documents since they're part of the curriculum. The knowledge that they gain is inherently baked into how they practice. So, worst case scenario, you studied, didn't pass, but you gained all that knowledge. A greater respect from peers and colleagues and confidence at work, an increased literacy of reading research, absorbing research when you're at the annual meetings or talks or workshops, following along much easier, literacy of the clinical guidelines, a greater understanding of all the different roles within a clinic, and overall a deeper understanding of what happens in the embryology lab, how counselors might teach their patients how to cope, why physicians choose the treatments they choose, the importance of administrative roles, how risk analysis works, how to implement changes in the clinic. All of these things make a fertility nurse or midwife more knowledgeable, more discerning, more agile in navigating new technologies and trends, and more able to advocate for high quality care. And then some things that I want you guys to think about when we have a discussion or a question and answer session afterwards is, do we think that extending our roles to credentialing and maybe taking ultrasound workshops, et cetera, will contribute to increased job satisfaction? Do we think that it might increase continuity of care or lower costs? Do we think that it could improve patient satisfaction? Let's say you're a nurse and you start taking over doing inseminations at the clinic instead of the physicians. Does that mean the patients wait less, that they come in, there's more nurses than there are doctors? Does that mean they get their insemination done rather than sitting around waiting? Is that patient-centered? Just an example. A couple other things that I want to kind of stew for you guys. In 2020, the World Health Organization called for an expansion and greater recognition of all nursing roles, including advanced nursing practice, to meet patient need for quality, holistic-based care. However, in the absence of global implementation, nurses and midwives working in reproductive medicine are being denied the opportunity of career progression. And then in the US, they have this American Nurses Credentialing Center has this magnet recognition model, which basically creates a KPI roadmap, meaning the infrastructure that's needed to have exemplary nursing practice, innovation, and quality care. Obtaining ESHRE certification pretty much inherently means that you also absorb some of ESHRE's values, which include that ESHRE is an inclusive society that champions diversity among its membership and encourages participation of experts in the field of reproductive medicine and science with different backgrounds from around the globe, different professions, different settings. ESHRE encourages freedom of scientific research and supports the view that science-based understanding of all aspects of human reproduction and the unbiased and evidence-based dissemination of knowledge is the path that leads to improvements in infertility care. Raising standards with the aim to improve fertility care is high on ESHRE's agenda and is a shared concern within the ESHRE community of infertility specialists. ESHRE's activities are based on the principle of respect for human dignity and the patient's universal right to infertility treatment. Honesty, objectivity, responsible behavior, and professional competence underscore this principle. ESHRE aims to stimulate international collaboration based on the belief that spreading education, sharing information, and enhancing the scientific and medical debate will help contribute to the worldwide advancement of the field of reproductive medicine and science. And ESHRE commits itself to provide support and share its resources in the best possible and most effective way to the realization of its mission and aims. Doesn't this sound like something you want to be a part of? So what are those global implications? The ESHRE logbook can be completed by applicants from all over the world, irrespective of the global cultural differences or the context in which they're working. There is scope, therefore, for ESHRE certification to achieve global recognition in advanced fertility practice, which recognizes the legitimacy of nurses to practice at an advanced level through assessing their qualifications, experience, and competence, which is known as credentialing in the UK and in the United States. So maybe ESHRE certification could meet the call by World Health Organization for expansion and greater recognition of all nursing roles. You know, if you want other examples of what's actually happened, you can listen to this great podcast series that we've put together on focus on reproduction. We interview certified nurses and midwives around the globe that have achieved this gold standard. Lisa Hughes Thompson is a certified nurse in Ghana who's now actually training to be an embryologist. Reminds me a little of Jean Purdy. She's also started a training program in Ghana for fertility nurses and midwives. Liana Edenius is an ESHRE certified midwife in Sweden who's been doing embryo transfers for years, and she's the go-to skills trainer for new doctors. Sarah Linden obtained ESHRE certification while she was working as a fertility nurse in the Middle East, and she's now back home in Ireland. And then you have me, not that I want to talk about myself, it's awful, but I'll let you know that it all started with ESHRE, actually very much with Helen, that now I'm part of the executive committee of the European Society for Human Reproduction and Embryology. There's more inspiration stories available online. We now have roughly about 200 nurses and midwives have passed the exam. We're in Ghana, New Zealand, Malaysia, Portugal, Norway, Sweden, Turkey, Greece, South Africa, Canada, Australia, Nigeria. The list will continue to expand. So what's in the future? Well, we're doing some follow-up surveys. This consensus for KPIs with nurses and midwives is underway. We want to grow the certification program. The special interest group for nurses and midwives is quite active in planning courses and webinars and raising the profile of nurses and midwives in our field. And what's next? Well, maybe we get some sort of official accreditation within the European Union. The embryology certification was just officially legislated in Slovenia as a medical embryologist, so maybe the domino effect will happen. And maybe us midwives and nurses are next. So we'll continue to push and lobby for formal recognition and credentials in Europe and abroad, and maybe we'll reshape the model of fertility care for the future. I hope I've inspired you, and I look forward to questions after. Thank you.
Thanks. Sorry, Robert, you go.
Thank you very much, Hilde. That was a wonderful overview and a lot of very important information for especially the nursing community, which I do hope will initiate quite a lot of further skills and knowledge that will be important for developing this field of infertility. And I think it's a fundamental part of the treatment, the part of the nurses and the skills of the nurses, because they have most of the contact with the patients. We doctors and clinicians have contact, but it's much less. So I think that is a very important part in the treatment, and developing the skills is a crucial part of developing our medical and healthcare all around the world. So thank you very much for all those initiatives that you are involved with and sharing it with us and with all the community today. And now it's my pleasure to move on and ask Valerie to present her presentation for today, the Novice to Expert Developing and Training and Education Framework for Fertility Nurses. So please, Valerie.
Thank you, Robert. I'll just wait for my slides to load also. Thank you. So the title of my session today, as Robert's just said, is basically considering reaching your full potential. I think Hilde touched on quite a few important points, but I'm going to focus on the training and education framework for fertility nurses that was actually published by the Royal College of Nursing in the UK. And this is my disclaimer and disclosure. And so on to the learning objectives. So in order to provide context to the Royal College of Nursing Training and Education Framework, I'll attribute my professional journey to the process. It's the only way I could kind of simplify it. The aim being that the learning objective should allow you to consider your own personal career progression and development within fertility or midwifery care. I'll also include references to professional guidance, which undoubtedly encouraged my personal career development before moving to advanced nursing practice and ending with 2 case studies which highlight the difference and valuable contribution, as Hilde has already touched on also, that we make as fertility nurses and midwives on a daily basis. So the first bullet point on this slide is an extract from the Royal College of Nursing Training and Education Framework in 2018, which was a revised version from the 2012 publication when I chaired the group from 2009 to 2013, with the final sentence describing the specialist area of practice and assuming increasing responsibility, a key driver in our professional development. But to reach this level of practice, we need to be mindful of the political drivers, future workforce requirements, and enhancement of nursing care, in which all continued education and multidisciplinary team collaboration are key requirements. Whilst I'm not suggesting for a minute that every nurse, fertility nurse or midwife will aspire to a master's level of advanced practice, every nurse has a right to reach their full potential, whatever that might be. And I remember having a conversation with a relatively junior fertility nurse several years ago, who I just knew she had great promise in the fertility sector. And I tried to encourage her to consider training in pelvic ultrasound. And I think I put that poor girl through so much anxiety and worry that she then came to see me 2 or 3 weeks later when she came for her annual appraisal to say, you know, I've been thinking about it, but I just don't think it's me. I'm just really happy being, she called herself a junior clinical fertility nurse, and an excellent clinical fertility nurse she is also. so. So it's just to remember that there's nothing wrong with that, but for people who do want to move up the career or progression ladder, then hopefully this presentation will help you consider that and give you some guidance. So again, I touched on annual appraisal. I know that that's maybe not a standard practice throughout Europe or globally, but in the UK, we manage annual appraisal, which is allows for a formal discussion with your line manager, and it allows for shared discussion regarding your strengths and areas of interest, which should be linked to your competence and knowledge to allow for you setting your objectives for the next year. So the framework acknowledges that many practitioners provide fertility care as part of an extensive clinical service, whether that might be in gynecology, midwifery, or oncology, and might want to develop knowledge, skills, and competence in specialist practice of fertility. For example, oncofertility, that would be fertility preservation, sexual health, early pregnancy, and as Hilda mentioned, recurrent pregnancy loss, the latter being a patient group in absolute need of ongoing psychological support, and which we as fertility nurses are trained to provide. And we'll also hear from Jen Ilya, nurse sedationist, who has an additional advanced practice role in providing the sedation service in her clinic in Scotland in the UK. So what about the theoretical influence on training and education? Dr. Patricia Benner is a theorist who developed a model for the stages of clinical competence in her classic book entitled From Novice to Expert, Excellence and Power in Clinical Nursing Practice. And her model is probably one of the most useful frameworks for assessing our needs at different stages of our professional growth. And this is one that we actually use. We use this model in our first RCN publication. So if we consider the descriptors for each level, starting with the novice practitioner in green, is new to fertility nursing, and we then advance to the beginner to competent stage, gaining knowledge and experience which enable greater understanding and processes in the context of long-term outcomes for our patients. And finally, the proficient practitioner assumes holistic approach to practice with continuity of care, and these skills are further developed when reaching the proficient stage of professional practice. And as Hilda mentioned about ESHRE certification, if you're considering applying for ESHRE certification, I would say that this is the perfect stage in your career to do so. And finally, the expert practitioner exercises skills in decision-making and can justify deviation from guidance or operating procedures. So I appreciate this next slide is quite busy, but it's an informative extract from the 2012 framework, which may be of interest if you're looking to top up your diploma or first degree for the purpose of professional development. And as Hilda mentioned in her slide, for ESHRE certification, we're looking for a minimum bachelor's level of study from applicants. So you'll see from the academic levels, they're cross-referenced with the educational level to be attained through higher education modules. For example, if you're looking to top up diploma to first degree level, you can select single modules from different colleges or universities from which you'll gain design awards or credit accumulation transfer points, as we call them in the UK, or CAP points, which when combined will either equate to a first or second degree level. Those aspiring to master's or PhD level would require additional credits. For example, a first degree requires 360 credits, with master's an additional 180 at a slightly different level of academia. However, levels of educational attainment shouldn't be confused with banding or levels of competency, which are frequently attributed to posts and used within the UK Government Career Framework for Nursing, and which are also aligned with salary. So it doesn't guarantee you basically promotion or a higher salary if you actually move on with your academic qualifications. So the RCN competency framework for career progression in fertility nursing is shown in this diagram, uses the 4 principles of the UK Nursing and Midwifery Council Code of Practice and professional standards. The framework has been devised to enable nurses to maintain and enhance their skills and knowledge in the specialist area, whilst allowing for diversity in career progression and our transferable skills to be used effectively. So if we first consider the first principle of leadership, we as fertility nurses and midwives are leaders in our own right. And as we develop our knowledge and competency in turn, this enables the acquisition of management and leadership skills. And this slide details the natural progression of leadership, albeit promotional posts usually aligned with academic accreditation, as mentioned previously. This diagram is also from the 2018 framework, which depicts the interacting or cross-cutting roles and responsibilities. The inner wheel applies to any healthcare setting, and this diagram is actually an adaptation from the curriculum for emergency medicine. However, the competencies have been adapted to focus clearly on fertility services, such as we start at the beginning, fertility assessment, including preconception care, provision of information and consent, medicines management, which we'll hear from Sue later on, documentation and record keeping, the surgical pathway, which is unique within the UK, and it's a Human Fertilisation Embryology Authority mandatory requirement for all IVF clinics in the UK to abide by the surgical pathway. Legal parenthood, safeguarding children and adults, including welfare of the child, infection prevention and control, and pelvic ultrasound. And if we focus on the outer wheel, this depicts a specialist area of practice, for example, fertility preservation, transgender care, same-sex couples, although I wouldn't put same-sex couples in the outer wheel. I think we should encompass that in the inner wheel, but it's a publication. Treatment of single people, again, I put that in the inner wheel. Donation and surrogacy, again, a little bit more specialist practice required to manage these client groups. All areas of opportunity for you as fertility nurses and midwives working at a proficient or expert level of practice. So with regards to career progression, the majority of nursing roles fall within the category of clinical practice, characterised by delivering direct patient care and providing nurses with a variety of roles in different settings. So most of us will gain a few years post-qualifying experience, which Benna refers to as generalist, before considering specialist or advanced roles, thereafter termed junior specialists. However, as I mentioned previously, it's not all about moving up the ranks, and you might instead want to explore a lateral move, for example, gain experience in a different clinical area or clinical setting such as community, research or teaching, or simply enjoy a new challenge or facilitate a lifestyle choice that fertility does offer us, because we're not working shifts, we're not working every weekend. And again, you might want to do part-time hours, again, an excellent area in which to do that. So, and as we progress our clinical and academic skills, we become more an advanced generalist who is qualified to master's level and who plans and provides direct patient care. And as an advanced generalist fertility nurse, you'll be expected to manage your own caseload and coordinate patient care, which might include pelvic ultrasound and embryo transfers, with some advanced practitioners in the UK also performing egg collections. And as a fertility nurse, consultant or consultant fertility midwife, you'll be expected to receive direct referrals and liaise with other members of the multidisciplinary team, such as consultant medical staff, other disciplines, for example, specialist obstetricians, oncologists, clinical nurse specialists, and in my previous role, I also liaised with the Department of Psychology, Mental Health and Endocrinology. Nevertheless, however varied or otherwise your journey might be, if I could give one piece of advice, it would be make every experience count and be the best you can be within that role. With regards to how we acquire skills over time, the Dreyfus model of skill acquisition was developed by the Dreyfus brothers at the University of California in 1980, and it's a learning progression framework. It argues that as one learns a new skill via external instruction, they pass through 5 stages of development, from novice to advanced beginner, competent, proficient, and finally expert. And so in 2001, Patricia Benner applied this model in an observational study of clinical nursing practice, focusing on newly qualified nurses and their mentors, and suggested that based on the analysis of careful descriptions of skill acquisition, as the student becomes skilled, they become less dependent on abstract principles and more on concrete experience. And I have to say, I absolutely agree with that. And to place this model in context, I've provided an example of my career and levels of proficiency at the foot of this slide. So as a novice, I was classed, as we call them in the UK, a staff nurse I worked in several different areas, but latterly gynecology, that gave me an insight into fertility practice. As an advanced beginner, I was appointed a senior staff nurse grade and was both trained in general and midwifery at that time. As a competent practitioner, I went on to study my advanced diploma in midwifery and then my BA honours in midwifery. I then became accredited in pelvic ultrasound and embryo transfer. As a proficient practitioner, I studied towards my master's in research and that led to several publications, but I also was starting to enjoy a national and international profile at this time. And as an expert, I am dependent on continuous professional development in my, my current role as consultant midwife and fertility specialist. And so moving to the highest level of clinical fertility nursing practice, the next few slides focus on the role of nurse consultant and midwife, the role which was first introduced in the late 1990s to enhance the quality of healthcare services. But where exactly does fertility sit within the wider organisation? In some authorities, it might be grouped with sexual health, in others, gynaecology, and in my previous role was actually situated within obstetric services. The role of consultant nurse or midwife encompasses a wide range of responsibilities, including expert clinical practice, leadership, training and education, strategic planning, which I didn't much enjoy, service development and research. The expectation being, therefore, that those working at a consultant level of practice is that you will have extensive and highly specialised knowledge in addition to strong interpersonal and communication skills. And I think all fertility nurses and midwives have strong interpersonal and communication skills. But you need knowledge, experience, and above all, adaptability in expert practice due to the unpredictability of workload. And this slide depicts the 4 pillars of advanced nursing practice and the necessity to be able to prioritise one over the other. But in my opinion, patient and clinical need should always come first. Within the UK, there are several drivers now having significant impact on the development of nurse consultant roles, including the following publications: the Nursing and Midwifery and Allied Health Professionals Framework, Better Health, Better Care, Modernising Nursing Careers, and implementation of Agenda for Change, which resulted in salaries matched to job description. And that was a huge amount of work, working through everybody's job description and making sure that they were on the correct band and salary for the job that they did. Therefore, the development of the framework, which builds on 4 pillars of professional practice, aligns with this. For me, this presented an opportunity to consolidate my knowledge and experience with my continued desire for information, my question and approach to practice, and never been able to make decisions or ask the question why. An example of this was my 2-year term of office with the Training and Education Subcommittee for the British Fertility Society. In my opinion, the logbook was outdated with specific theory for nurses. The group at the time were unwilling to change or update the logbook, so I developed my own. And in accordance with specific ultrasound systems, I sought peer review from our systems application specialist, who was amazing, on the use of physics terminology, something that wasn't my strong point. Thereafter, being registered as one of 2 pelvic ultrasound trainers in Aberdeen for several years. I was also fortunate to be seconded for almost 5 years from my clinical post to complete research projects and also be involved a little bit of teaching with the University of Aberdeen. And that also gave me insight into grant writing and the understanding the role of research governance and good clinical practice, which enabled the critique and peer review of several qualitative articles for fertility associated journals. So I think I've moved forward 1 extra there. But with regards to professional body representation, there are numerous opportunities which are invaluable for reaching your full potential. But above all, it's not just local, but global networking. Again, Hilda touched on that in her presentation. So my professional body involvement began in 2006 when I joined the Royal College of Nursing as a committee member. I absolutely love the professional and educational side of the membership, but not so much the political side. And you might not think this, but I wasn't as vocal back in the day. I used to leave that to my more vocal colleagues. So this led to chairing the committee several years later with several publications, including the first competency framework, followed by the training and education framework and guidance documents. In 2007, I was invited to join the HFE editorial board and the One at a Time initiative to address the rising multiple birth rate following IVF. 1 in 4 births recorded as a result of IVF treatment, 20 times higher than the natural conception rate at the time. And we met our multiple birth target of 10% for the first time in 2017. And that has now been reduced to under 5%. I think it's about 3% across the whole of the UK sector, having been reduced from 24% in 2008. And this was a perfect example of national collaboration between the fertility sector, the regulator being the HFEA, patient groups, fertility professionals, namely fertility nurses, neonatal experts and commissioners. So in 2016, so I've moved on, I've clicked a bit too early. 2016, I was registered as a pelvic ultrasound trainer with the BFS, later appointed to the Training and Education Subcommittee, and I really enjoyed planning nurse sessions for the society. And I also implemented collaborative working with the Royal College of Nursing, encouraged a member of the Royal College of Nursing group to attend one of our meetings, and equally a member of the BFS subcommittee would then attend the RCN meetings, and that worked really well. And latterly, I was invited to join the ESHRE Nurses and Midwives Certification Committee and appointed chair in 2022. And as Hilda has already described, ESHRE certification provides and offers a formal recognition for nurses and midwives with a specialist interest in reproductive health. It was also in 2022 that I was invited to join the Medical Education Academy Board of Experts, and this webinar is an example of the valuable work of the Academy, providing free registration for nurses and midwives. I was already peer reviewer for the Journal of Human Fertility, in addition to another 3 journals specifically related to fertility, and then invited to join the editorial board in 2021. So all I can say is, if you haven't already considered professional body representation, get involved, get out there and share best practice, and above all, enjoy the socialising along the way. And so moving on to my professional career, which can be placed in context with the Training, Education and Career Framework, my professional journey began in Edinburgh following completion of my general adult training, followed by midwifery several years later, both which informed my fertility nursing journey. Whilst my first few general posts were related to emergency medicine and neurosurgery, I applied for a promotional post in gynae, which provided my first insight into specialist fertility practice and evidence-based medicine. There were 2 private rooms through the back that one of the consultants used to disappear through every so often. I was then asked to attend to this lady, give her a cup of tea, and I went through, and she was lying there with her pelvis elevated on 3 pillows and advised not to move for 4 hours. That was my first introduction to intrauterine insemination, but obviously hadn't a clue what had gone on. That was back in the day when there wasn't the HFEA code of practice or consenting to intrauterine insemination, but that was my first insight. And so there's no doubt that the additional study, moving on to the study for my master's, I was afforded excellent supervision through the University of Aberdeen, and that led to 3 publications as a result of the master's degree. And there's no doubt that the additional study enabled my applications for consultant nurse and midwife roles. Studying at a master's level of practice does give you a more questioning approach to practice, and that has definitely enabled my career progression. So if you're interested in progressing your career in fertility, this slide will give you an idea of the background, which refers to the development of the fertility preservation post, which was to be the first of its kind in Scotland, with nationally agreed criteria, funding stream and standardised policy and protocols to be used consistently across NHS Scotland, which is the government healthcare service, which would also ensure equity of access, in particular for young people diagnosed with cancer, reducing geographical and organisational barriers. Inevitably, this led to the integration of fertility, oncology, endocrinology, and also transgender services, with continuity and improved quality of care for patients at such a critical time in their lives. Fertility preservation not only offering the chance of future fertility, but discussions that included life after cancer, not if I survive my cancer, and more importantly, what should be perceived as a positive part of cancer care. However, despite positive feedback from patients, haematology and oncology colleagues, after 2.5 years, funding was no longer supported for my post by the fertility management team. And therefore, if you're considering role progression and implementing service change, it's crucial that you have a supportive management structure. The next two slides for me provide insight into the difference we do make enhancing the patient journey, with the first case being that of a 29-year-old with a history of multiple first and second trimester pregnancy losses. Recurrent pregnancy loss investigation results, that's lupus anticoagulant and anticardiolipin studies, being negative. In 2022, she had a preterm delivery at 29 weeks for placental abruption. In February 2024, she had a positive urine pregnancy test, resulting in an incomplete molar pregnancy, the management being evacuation of retained products of conception and HCG tracking. In June of this year, she presented at private practice with a positive pregnancy test, having had no period since her pregnancy loss in February. Pelvic ultrasound revealed internal yolk sac and fetal pole. However, it also revealed what appeared to be an abnormal cystic endometrium, which I discussed with my medical colleagues, and given that there was a live, normally cited intrauterine pregnancy at the time, suggested conservative management. Unfortunately, she miscarried, and thereafter my colleague referred her for a hysteroscopy, and she was finally diagnosed with Asherman syndrome. Nevertheless, irrespective of outcome, if we strive to make a difference and provide quality care every time, we will enhance the patient experience. My second case study relates to a 25-year-old female diagnosed with stage 3 thoracic neuroblastoma in 2010, who relapsed in 2014 and again in 2018. Following joint endocrine fertility consultation in 2019, had myeloablative therapy and autologous stem cell transplant. She attended the fertility centre for medical consultation and perceived this consultation to be insensitive, the doctor portraying a negative fertility prognosis. Myeloablative treatment involves high-dose radiation and chemotherapy, therefore is highly toxic to ovarian tissue and required an in-depth but sensitive consultation. Therefore, my approach was very much from the psychological perspective. Findings from the pelvic ultrasound help inform the discussion, leading to understanding of the complex needs in the context of pregnancy that may never be realised, and parenthood, which actually may be an option through egg donation, surrogacy, or adoption. And therefore, as fertility nurses and midwives, we have a duty of care to provide holistic and compassionate care, which enriches the patient journey, irrespective of outcome. And so for me, my educational journey began at school with specific teachers inspiring my questioning approach. I was always the one that still had my hand up at 5 to 4 when the bell was due to ring at 4 o'clock. Followed by my nurse and midwifery training and varied nursing experience, with gynecology facilitating my interest and affiliation with fertility. But to be eligible for a promotional post at that time required additional qualifications, which led to midwifery training and the opportunity to apply for the fertility post. I've already detailed my fertility journey and academic affiliation with the University of Aberdeen, and therefore I believe in the context of education, we come full circle, nursing and midwifery providing the opportunity for lifelong learning. And so to conclude, and in accordance with the RCN training and education framework, which you can use to facilitate a conversation and enable career development, my take-home message is, as fertility nurses and midwives, we provide a holistic approach to fertility investigation, treatment, preconception and early pregnancy care through compassionate, informed and evidence-based practice. And remember that we are privileged to share our patients' fertility journey and work within a specialist area of practice with numerous opportunities to assume increasing responsibility, which for me, and I hope for you, will be immensely rewarding. Thank you.
Val, thank you so much. That was just the most amazing presentation. Difficult to believe that you were ever a quiet little mouse at the back of the room.
I know. Well, I thought I would get that in for those of you who know me well now.
You've had an amazing career, and to lay that out before us to show how we can develop ourselves is really inspiring. So thank you so much in conjunction with Hilda's great presentation. There's lots available for us out there. So thank you very much. It's my great pleasure now to introduce to you Kate Bryan, who actually, I think you started your career as a journalist, Kate, and you've written 5 books about fertility treatment and pregnancy. And I recall you visiting our clinic, in fact, And we were all delighted to get a little thank you and acknowledgement at the beginning of your book. So I don't think I ever thanked you personally for that, but thank you very much for that. Kate's most recent work, I suppose, is that of being the co-founder of a comparatively new charity, the Fertility Alliance, which is a UK-wide charity which is helping support patients with information and general support about treatment. And you have reached the lofty heights of being an honorary fellow of the Royal College of Obstetricians and Gynecologists. And I think you were the first women's lead of their Women's Voices group, which was at the time sounded to me so inspirational that we're actually thinking about putting women who gynecologists and obstetricians are looking after right in the center of what they need. And you're going to lead on with that today, carry on that work by talking to us today about what we should do as nurses and midwives about managing patients' expectations. Because I think we've got it right. We'll often say, but I've given them all that information. How can they still have questions? And hopefully you can give us some really useful insight today. So welcome, Kate, and thank you for your time.
Thank you so much, Helen, and thanks for that lovely introduction. Very kind of you, and thank you for inviting me to your clinic all those very many years ago as well. So I'm going to talk a bit about patient expectations and about the role of nurses in supporting patients. And I just need to go back to the beginning there. I think that actually nurses are really the most important people in the clinic, because as a former patient myself, I know that it's nurses who we often have the closest relationships to and who we feel able to talk to the most. And midwives play a really important role in the post-treatment experience as well, if you have a successful outcome. But I think in order to understand anything about the patient experience and how best to support patients, we really need to start by thinking about the emotional impact of fertility problems and treatment. And this was a big survey done in 2022 of more than 1,000 patients. And 83% of them felt sad, frustrated, and worried often or all the time. And I think it's important to think about what that actually means. That means they wake up in the morning feeling sad and they go to bed feeling sad. You know, infertility is so corrosive. It influences every single aspect of your life. The majority of them had also experienced anxiety, feeling out of control, stressed, tearful, helpless, inadequate, isolated, angry, despairing. People had low concentration, reduced sex drive, and feelings of guilt or shame. So the impact of fertility problems can be really overwhelming. And 47% of them had experienced feelings of depression, often or all the time. And I think if we want to really understand quite how overpowering those emotions can be, we need to look at the number who said that they'd experienced suicidal feelings. 40% of patients, 10% feeling that way often or all the time, and another 30% sometimes or occasionally. And what's quite interesting about that is a similar survey in 1997 found that just 20% of the patients had experienced suicidal feelings. And we could speculate on why things have changed. Maybe people are more open to talking about their emotions, or maybe it's partly because I personally think there's a lot more pressure on fertility patients now than there used to be. The other thing that's having a huge impact here in the UK, particularly at the moment, is waiting times. And we did a survey earlier this year showing waiting at every single level of the patient experience. So people waiting to be seen at a clinic, people waiting sometimes really long times. 14% have waited more than a year to get to the clinic. They were often having to wait for other tests or procedures before they could start fertility treatment. And almost a third of those who were waiting had waited more than 6 months. And really long waits for NHS treatment after being told you'd actually need treatment to actually starting it, with more than 20% waiting for more than a year for that. And what we found most upsetting about this survey, and it's very much reflected in a big piece of work that the RCOG put out just a few weeks ago here in the UK, which showed terribly long waiting times for all kinds of gynecological treatments, is the huge impact that this is having on people's mental health. Because as a patient, you become really worried that it might mean, these delays might mean that you actually don't ever end up having children of your own. And I think because of that, many patients then feel pushed into the private sector, not really through choice, but through necessity. And the Competition and Markets Authority here in the UK, the CMA, did some work around IVF and looked at pricing. And they concluded that the prices of treatment aren't always clear. A third of the respondents to our survey said it wasn't clear how much their treatment was going to cost. There were often really unexpectedly large bills for things like blood tests and scans. One person who responded was charged more than £500 just for blood tests, and she had no idea this wasn't going to be included in the overall cost of her treatment. So I think it's really important to do whatever you can to be really clear with patients from the very start about how much treatment might cost. And I feel personally that one of the really big issues with that is there's often very little awareness in the fertility sector of quite how little some people earn and of quite how hard it is for ordinary people to find the money to pay for IVF. So our survey found that 30% of the respondents had borrowed from their family and 27% had used credit cards or loans to pay for their treatment. And that might be fine if the treatment works, but it's maybe not so fine if they're then left wondering how they're going to finance another cycle. And inevitably, expectations are high when people are investing so much financially as well as emotionally into a treatment cycle. And it's not just their expectations, it's all those around them, all of their family and friends, especially those who might be wanting to pay, feeling that they've helped someone to have a baby rather than an unsuccessful round of treatment. So what is the patient experience in the clinics that you're working in? Well, the HFEA here did a really interesting patient survey in 2021, and it found that although 2% of patients were satisfied with their experience of fertility clinics, many weren't. And it's actually a reduction in the previous survey that they carried out looking at patient experience. And I think there's a temptation to think, well, 70%, that's kind of fine, isn't it? But actually, that means that almost a third of patients are not satisfied with their experience. And I think satisfied in itself is quite a low level. It doesn't mean that patients were thinking that they had a really brilliant service. And we often hear from clinics when we present presentations on things like this, oh, well, yes, patients are never going to feel satisfied if they didn't get pregnant. And that's probably why we see these kind of figures. But when we talk to patients, what I find really interesting is that lots of patients who haven't had successful treatment will still say, oh, actually, my clinic was brilliant. Whereas sometimes patients who have ended up pregnant don't feel that they were at the best clinic with the best kind of service. So I think it certainly shows that there's still some room for improvement there. So what were the things that patients weren't very happy about? Well, there are a number of key areas of concern. And the first one was around the level of support, and that included access to counselling. Patients often say to us, there's lots of medical support. Clinics are very confident and sort of focused on offering the best possible medical and scientific care to patients, but there's not always so much focus on the emotional side, which is just as much a part of treatment if you're a patient. Another thing they weren't happy about was the cost of treatment, because it wasn't always clear how much it was going to cost them. And add-ons, we know the additional treatments that patients are sometimes offered now can make treatment even more costly. So patients want clarity on that. Another thing was not being treated as an individual. And patients sometimes describe clinics as being very impersonal and feel as if they're being pushed through a kind of process where everyone's very busy and getting on with their jobs, but not really treating them as a person. And they sometimes can feel as if all anyone's actually interested in is their money at the end of the day. They sometimes say they feel there's a lack of compassion, that clinicians forget quite how important this all is to you as a patient. You're leaving your precious eggs, your sperm, your embryos in someone else's hands, and you have to really feel that you can trust them. Patients say sometimes they feel that everyone's in a rush and slightly dismissive of them and their concerns. Another area that seems probably a bit insignificant is around admin. And I think it's really important to remember how much things like getting the wrong letter or not getting a letter in time or not getting an email or people being a bit confused about what they're there for can make such a difference to a patient experience. And yet they're kind of small things that probably don't take quite as much to change, but can really make so much difference. And then finally, one of the biggest ones is around gaps in the information provided during the fertility journey. And we know that getting accurate evidence-based information can be a real problem from the start to the finish of the journey. And I think that as nurses, you can really help patients fill in some of those information gaps. One of the big problems, I think, at the moment is that there's almost too much information out there, too much information, too much advice from too many people. It's really hard to make sense of it. People want to do whatever they can to make a difference. So they're hungry for all the information they can get. But if you Google anything to do with fertility, you get hundreds of pages of information. And there are so many people now, especially online, giving their own advice about what patients ought to be doing. It can be totally confusing because half of it's contradictory. For example, I'm sure you're all familiar with the advice about pineapples. There's a lot of it out there on the subject. But some of it's very precise. So sometimes you hear that it's only the core you should eat, and you should shave it into 5 slices and eat 1 slice each day for 5 days. You may also, however, find that you're meant to drink a pint of pure pineapple juice a day. But then there are others saying that you should avoid pineapple juice at all costs and only eat the core. Then there's the advice about McDonald's fries. You should eat a portion as soon as you can after your embryo transfer to improve implantation. But then there are some people telling you must avoid junk food at all times, at all costs. So who do you believe? Which is right? The one thing people do seem to be agreed on is that you need to keep your feet warm at all times, because apparently having warm feet equals an inviting womb. But there are so many people out there telling you so many things. There are all the complementary therapists. And I think that now some patients almost have the idea that if they don't do acupuncture, it means that IVF isn't going to work. We know that it's a really common thing for patients to do. There's even a type of coaching here in the UK which claims to double IVF success by the power of positive thinking. It's very expensive. It costs nearly £1,000 for a cycle, which you do alongside your treatment. But what's really worrying about it is, can you imagine how bad someone feels if, having paid that much money for coaching in positive thinking, then their treatment doesn't work? Who's to blame? I think often it can only be their own fault in their heads because they feel they haven't been thinking positively enough. So what do your patients need in terms of information? Well, I think the more honest, evidence-based information you can give, the less your patients will need to seek out this kind of non-evidence-based information online. And the more you can help to give them realistic ideas about what can and what can't make a difference. So the RCOG did a survey in 2019 asking women for their views about the information on fertility, and 86% said information about fertility was confusing and contradictory, and 76% of them were not sure it was impartial. It can be incredibly difficult to know who you're meant to trust when every clinic and every doctor seems to be telling you something different and giving different advice. So I think the crucial thing is, when you're with your patients, listen to what they're asking. Think about how anxious and worried they may feel. Let them ask those silly questions and back up everything you say with written information. I'm not suggesting you hand out piles of leaflets, but give them links to reliable sources of information. Think about the sources of information you trust yourself and share those with your patients, because then they're less likely to find the unreliable sources. Try not to use jargon as well. It's your world and it's your language. And I think sometimes it's easy to forget what things that you use every day may not make really very much sense to your patients. We know that you can't always tell someone exactly what their chances of success might be. But I think it's really important to try to give them as much information to put that into context as you can, because information right across the board helps patients to feel more in control. And when patients feel supported and well informed, they're going to be calmer and less stressed. They're less likely to get upset and less likely to be full of worry and questions. So I think it can actually make your job easier. And I think one particularly difficult area in terms of information is around the additional treatments that some patients are having now, where they often have a very different understanding of what it is they're paying for. So I think clinics sometimes say to patients, oh, this might increase your chances of success. And by that, they might mean it might increase your chances of success by a few percentage points. But what a patient actually hears is that this might make a difference between your treatment working or not working. And we aren't against patients being offered additional treatments, but we do feel very strongly that they must have the information to make genuinely informed choices about that. The other thing I wanted to talk more about was around patient support needs, because we know that at present, not all patients are being offered counselling. And here in the UK, it's actually a licensed condition. So clinics should be making the offer of counselling to all patients, but patients don't feel that they're always getting that. And I don't know whether that is because they're being told about it in a way that doesn't come across very clearly to them. But we're often told that patients don't want it. But on the other hand, patients often tell us that it's barely mentioned in their clinic. We have a people's panel at the Fertility Alliance who we talk to regularly, and 56% of them felt that clinics didn't provide the emotional support they needed. They wanted ongoing counselling to be included in the cost of treatment, and they felt, and we very much agree, that the emotional aspect of going through treatment was an integral part of the treatment process, and it should be seen as that. And I think kindness is one thing that with that can make a really huge difference. It doesn't cost anything, it doesn't take any more time. And yet, sadly, one common theme from the HFEA survey was that patients didn't always feel that clinic staff had time for them. And these are a couple of quotes from fertility patients, which I think sum up what the experience can feel like from the patient perspective. And I think they're worth thinking about. So the first one, everything at the clinic was very positive, very focused on the bright side. No one mentioned what happened if it didn't work. No one talked about that as a possibility. And I think getting that balance right between being realistic about the chances of success, but also, not making your patients feel depressed about everything from the start, it can be quite hard to get right. And we understand that, but I think it is important that there is some acknowledgement that treatment doesn't always work for everyone. The other quote, it felt like a conveyor belt. It was often really rushed and we felt hurried, as if we were annoying if we asked questions. Sometimes I wasn't sure they knew who we were. And I think patients shouldn't ever be made to feel like that. We know fertility patients aren't always easy because they're upset and they're stressed and they're going through a difficult time in their life. But I do think even if you haven't got long, trying to make it feel as if you do have that little bit of time just to listen to them can make so much difference. The other thing I just wanted to mention briefly was about partners, because I think that sometimes partners don't feel very included in treatment, and we can get very focused on the emotional needs of the person going through treatment. And I think sometimes clinics can actually exacerbate the idea that all the emotional burden is with that one person and that the role of their partner is very much to support them. I mean, I've actually seen guidance on how best to support your partner through treatment, but that can make it even harder for a partner who feels that they have to adopt the supportive role, because then they can't admit that they have their own emotional needs. And sometimes they don't seek out help dealing with them. When we know that counsellors often see the person going through treatment and don't always see their partner as well. And I think when you're making an offer of counselling, it's really important to make it clear that it's for both people. It's not just for the person going through treatment. And of course, it's not just male partners. I think it's also about creating an inclusive environment so that same-sex partners feel just as included too. And we often hear about clinic admin forms, pieces of papers that people are filling in, which just assume that the partner is going to be male rather than female. And I think all of those things are worth thinking about, because they're small things that you don't always notice, but things that can make a huge difference to how a patient feels about their experience. For those working in clinics, I think there are some really simple things that you can think about that make a huge difference to patients. So first of all, how do you communicate with patients? I think sometimes some clinics now are using apps quite a lot, which can be really helpful. And a lot of patients have been really positive about that. But I think patients do need to really know who they can get in touch with if they're concerned about something and who they can talk to. And just having a point of contact can make so much difference, because when patients are calling with anxieties and not able to find anyone to talk to, it can just leave you feeling so frightened and so scared. And going through treatment can be quite frightening and quite scary. The other thing, as I mentioned before, was around the admin. And I think that can be a huge thing. Just small little admin things can make patients feel anxious. If you're leaving your embryos with people, you need to feel confident that they actually know everything about you, that everything's in the right place. And I think those things which can seeds of doubt in a patient can be really corrosive and really difficult. So it's worth thinking about that. Another thing is around, do you know who your patients are? Which might sound ridiculous. Think, of course, we know who our patients are. But I think quite often we hear from patients that every time they go into the clinic, they see a different member of staff. And we know that you can't always change that. You know, that's just one of those things that can happen. But sometimes they say the person that they see didn't really seem to know anything about them. They had to keep looking things up. And a lot of the appointment time was spent doing that. And again, that doesn't foster confidence. And I think you can really make a huge difference by just spending time looking through the patient's notes before you see them. And finally, and I think the most important thing of all, is that all your staff understand the impact of fertility issues. And sometimes when people are thinking about kind of educating staff, they think about the counsellors, they think about the doctors, they think about the nurses, they think about the embryologists. They don't always think about the receptionist. And yet actually the receptionist is the first person that your patient sees when they come into the clinic. And that gives the first impression of what your clinic's like. And I think making sure that everyone is on board and everyone understands can make such a difference, because we hear from patients sometimes who say, oh, you know, I had to go in and the receptionist didn't seem to understand what I was talking about. All of those things can make patients more anxious and more worried. Finally, I just wanted to talk briefly about needs after treatment, because I think there's sometimes this kind of idea that, oh, we've done the treatment, that's it, it's all over now. You know, if it's been unsuccessful, I think patients often report to us that they feel incredibly abandoned. And they are sometimes, well, usually, I hope, offered a follow-up appointment. But I think they can feel very left out and as if they've failed the clinic in some way. And I think it's really important to do what you can to support them at that time, you know, not just a follow-up appointment, but maybe also suggesting that they should see the counsellor, maybe also referring to them to relevant charities or networks where they can get more help. But it's not just after unsuccessful treatment that patients need help. It's also after successful treatment. And I think when people get pregnant, there's this idea that, oh, marvelous, now you've gone back into the real world, no need to worry about any of this anymore. But I actually feel so passionately about this that I wrote a book about it, because I think there's an assumption that with a positive pregnancy test, people put their fertility journey behind them and move into the sunlit uplands. But it's just not like that. You know, former fertility patients are incredibly anxious during their pregnancy. Their bodies have let them down so many times that it can be really hard to have any confidence in your ability to have a live birth. Patients often have higher levels of anxiety, both antenatally and postnatally. And I think even as parents, IVF parents often set themselves unrealistically high standards in the early days and feel that they can't complain or can't find things difficult, that they have to be constantly in a state of joy and cheerfulness. And I think midwives understanding the fertility journey can make such a huge difference to fertility patients. But finally, I just wanted to very briefly tell you about our new charity, which was registered in December last year. So we offer support and evidence-based information. We work with the sector to and have very strong professional support. We also work with the patients and the public, and having patients involved in everything that we do and co-producing things is as important to us as working with professionals. We campaign for fair and equitable access to treatment. We also support research, because we feel gold standard patient and public engagement in research is vital, and we operate in an open, ethical and transparent manner. And finally, I just wanted to say thank you, and to say to you that, you know, we understand that not every patient who comes through your door is going to leave with a positive outcome and a pregnancy. But I think what you can do is you can make every patient leaving you think that they've done their best and that they went to the right place and that they were supported. And it makes it so much easier to leave without a successful outcome if you can feel that. So thank you very much.
Thanks very much, Kate. That's given us lots of things to think about. And I think Robert is here to chair the next part of this webinar, which is where we're going to be asking questions of all our panelists or the speakers from this first session.
Yes, thank you, Helen. Sorry, I interrupted you.
No, not at all. You carry on.
Okay. Well, thank you. I thought also it was a very practically based presentation, which really is important of answering everyday's questions and how do we go. So I enjoyed very much your lecture, Kate. And it's now time after the three presentations, lovely presentations, to ask some questions, give some answers. And up to now, I only saw one question asking how I can apply in UK for to become an IVF nurse. So maybe our UK members might answer that.
So, so the question is, can you apply to be a fertility nurse in the UK? Where's
Yeah,
the applicant?
how do you do that? How do you do
Okay,
that? Yeah.
okay. So if they're practicing it or have qualified in a different country, first and foremost, my understanding is that they would need to be assessed by the Nursing and Midwifery Council, so the NMC in London, to inquire initially whether they're able to practice on their certificate that they've acquired in a different country. That being the case, they can apply to any fertility centre. If they've no women's health or fertility experience, they would basically be employed as a junior fertility nurse and would start in that way. But I'm not sure if I've answered that question properly. I'm not seeing that question on the screen, so.
Yeah, it was the Q&A part.
There was something
was
else
also,
about needing to be a member to obtain the certificate. Do they mean a certificate for attending this webinar or ESHRE certification?
Might be the ESHRE certification as well. So maybe Hilda can tell us about that.
Yeah, the exam is in English. The curriculum and reading list is in English. But as long as the knowledge base is there and you're able to understand the questions of the exam, then absolutely anyone can apply. You have to meet the requirements which are listed on the ESHRE website. It does require a bachelor's, that is a minimum, and 2 years of experience, but you also have 2 years to fill out the logbook. So even new nurses and midwives can start working on the certification from the moment they're hired, basically, which is one of the things that we changed, was lowering the number of years of experience required, because we felt that this was also a way to encourage new people in the field to come out strong, and that it could almost even be used as a training guide if you are hired at a clinic. So that is something to note for clinic managers, that you could also borrow this as basically your curriculum for onboarding new people. Val, one of the things that you guys are looking at within ESHRE is, in the land of the modern world of AI and chatbots, if there's some way that we could be able to expand the ESHRE exam to be in different languages. But obviously that is a huge undertaking, and we recognize the need. We'll look at it, but it's a much bigger thing to try and make happen. But as nurses, we've got our fingers on the pulse. We're good communicators. We get it. We understand. So we are working towards it.
I'll come in there, and I know Helen's got a point as well. I actually put that to the committee and to the certification committee, so chair of certification committee last year when the exam obviously was available online. I'd also attended the Turkish Society of Reproductive Medicine conference, and you walk into the room and you're handed a headset and the presentations are translated in whatever language you like. And I think, why can't we do this for the exam, for the logbook, etc.? So it is something that I'm really keen to take forward. But at the moment, I was told that it's not possible, but it's certainly something that we would like to see in the future. And I think that Helen has a comment.
Yeah, Hilda, could I
Ah.
just ask you, do you have a buddy system for support for people going through the certification course with ESHRE?
Yeah, great point, Helen. There is a pairing that we try to do within the committee, Value running it now, where we ask those that are already certified if they're willing to be a mentor to other people. It's an informal mentorship. Many have said yes, and basically you just make yourself available to people who are interested. And so if it's a question, or they want to know what it was like to take the exam, or how did you complete this task, because we don't do this in my country, what did you do, or those kinds of things. So that's an informal mentorship, but ESHRE does take on board to partner up people, at least share a name. It's all GDPR approved, so that's okay.
Thank you.
Yeah. Mm-hmm.
Helen, Hilda, I also have a question. Looking at the curriculum and whatever they have to accomplish and the questions and so on and the time, it's quite a lot that's demanded for the certificate. And I was wondering if it might not make some of the younger nurses a little bit being afraid to start the journey. And maybe this is just an idea to implement maybe a sub-certificate, something which is a little bit easier to achieve, and to be as a starting point to achieve that first certificate, which should be maybe a little bit easier to get it. And then you will have a much larger community to start with to go to the next step of certification.
Well, I think
just an idea.
Yeah, it is something that we've looked at, but let's not underestimate the competencies that we actually already have. The idea is creating good benchmarks. And remember, the certification was created by panels of experts and surveys and interviews. It wasn't just some people thinking we want to do this. It's evidence-based, the way that it was created. So the level that it's at, I think, is correct. The embryology exam has a lower pass rate than the nurses and midwives by far. So what we're doing and the resources that we provide are reflected in the pass rate. In terms of who applies, we have to expand the certification. We have to grow it. All of these kinds of comments are noted, and it's nice to hear that type of feedback. But I don't know that the strategy, given everything we've talked about today, is that we should lower the benchmarks. I think we need to be very clear about where they are, and this is an option for people. It's not something that they have to do, and it's a way of creating that career progression. But I'd like to open that up to the other people.
No, what I meant is not to lower your certificate demands, but to do it stepwise. So to achieve it and within, let's say, 1 or 2 steps in between, which will make it more easier for the nurses to get into it, and not to be confronted with a huge thing that they have to accomplish.
For sure,
now.
I recognize that. It is a 2-year program. You have 2 years to complete the logbook, all the while you're studying. And the study buddy that's created directly links the curriculum with the reading list. And on the ESHRE eCampus, we have lectures for every single section of the curriculum. It's quite extensive. So it is, you were given 2 years, but, noted. I'll let someone else answer now.
Thank you. Just to come in on that, last year, 2 years ago, we had actually quite a high failure rate. So we went back to look at the applicants' academic level of study, and the majority of people who failed the exam didn't have, weren't educated to degree level. They'd maybe undertaken a hospital-based training or a 2-year equivalent to a diploma-based training. So we made it very clear, in my opinion, I didn't want people to be failing the exam. I didn't want to create that unrealistic expectation of success. So that's the reason that we have said bachelor's level of study, because I do feel that the exam is pitched at a master's level of study, and I didn't think it was fair. And that's why I'm trying to get across the message that if nurses and midwives out there would like to apply for certification and don't have that academic level of study, consider studying for additional modules that you can pick up from any college or university. You can study online. You don't have to attend in person. So it's just trying to get that and trying to encourage people to be the best they can be, and help people, enable nurses and midwives to apply that maybe weren't eligible previously. If I can, I was just going to touch on something that Kate had said in her session. Again, I'm working now in private practice, so all these patient portals and things, it's quite a new concept for me. And the majority of patients that I see, that is how the clinic communicate with them. And I would say the majority of patients feel that they're being done a little bit of a disservice, that they just want to be able to speak to somebody. A portal does not allow for answering questions and understanding the information that's then passed back. You know, they're told to either continue with their medication and rescan or whatever, but they maybe want to ask a few more questions about the findings of their scan that day, or their medication, or could you just go over again what happens next? Just that little bit of information goes a long way to reducing patient anxiety. So that was a really good point. So thank you for bringing that up.
Yes, I'm looking now at the Q&As here, and connected to that, there is a question here: why we need to do an ethical dilemma paper? Why not logbook only?
Will I answer that one again?
That? Yeah.
Again, it's encouraging not just a question approach to practice, but to encourage referencing a piece of work. You know, some applicants may never have written for publication before, and we're not advocating that that's the level we want them to be at, but we want them to think about the ethics of reproduction, the ethics of the clinic that they work within. And you know, there are a couple of ethics papers that came back, and you know, where things are permitted in one country, but they're maybe not permitted in another, and you have to give allowances for that. But as long as they can justify you know, ethical practice within their clinic and reference that practice, we feel again that it reflects a certain level of academic ability, and I think it's good practice. But maybe Hilda or Helen has something else they might want to add to that.
Helen, do you want to say?
No, it's fine. You go. I was going to ask Kate something, so you continue with your.
Okay. Well, one of the you know, values of ESHRE is equitable, ethical care. So it's inherent in human reproduction that it's such an existential thing. And there's a lot of ethical questions that come up in our day-to-day practice. The ethical dilemmas don't have to be very complicated. It could be, for example, a large age difference between two partners, right? It could be disclosing that egg donation was used for the treatment, and how do you bring that up with the child? So it doesn't have to be very complicated, but it is expected that there's some reflection around what we do, and it's also core in medical practice, nursing practice, pharmacists. I mean, there's an ethics module in almost every country's education framework for working in healthcare.
And I think also, just to add into that, there are countries where you can do some treatments and other countries where you can't do those treatments, and to encourage ethical debate. If you need to fill in your logbook as part of the certification course, you know, for example, let's say surrogacy, you need to have some understanding of that, and it'd be quite useful to use that as your ethical base case to have a group discussion in your clinic maybe. Kate, I was really interested in what you were saying about training all the staff, because as you say, we're really good at training doctors, nurses and embryologists and counsellors. And clinics I've worked in, we've orientated everyone from day one to go and work in every department. But of course, you're new to the clinic. You just about know where the kitchen is to make the coffee, and suddenly you're watching an egg collection, etc. And we had just thought I would share that we had a group of fairly new administrators, and they were all really sparky, bright youngsters, really, really personable, very kind. And they were great with patients, but they were really hungry to have lots more knowledge. And we used to have a kind of lunchtime, not a journal club, which we will all be used to professionally, but that kind of thing where we would go through treatment and they would write copious notes and then feel really pleased to be able to speak to, you know, Mrs. Smith or Mr. Brown and say, oh yes, that won't hurt, or don't worry, they'll talk to you about injections. So it's really positive thing to do. How do you think we get around the cost issue? Have you got any pearls of wisdom about clarity of costs?
I think it's really hard. I mean, I think one of the problems at the moment is this idea of not including everything on the cost that you're giving patients on your website. Now, obviously, you can't always include medication because you don't know what level of medication an individual patient might need, so you can't put that on your website. But like, why are things like anesthesia for egg collection or scans or blood tests, which every patient is going to need, not included in an overall cost of treatment? And I just think it's very unfair, because as a patient, you know, you might go along thinking, oh, well, maybe I won't need that anesthesia. You know, when you're starting out, you've got no idea at all whether you're going to need these things. So I think it's really about being fair and being as honest as you can about that from the outset, because I think, you know, if a patient's seen on your website that something's going to cost X amount of money and they've gone through their finances, worked out how they can have that much money, and then sometimes it's more than double that when they actually get there, you know, that is just immensely difficult to deal with, particularly because a lot of people don't actually have that much money. You know, our survey showed they didn't have that money sitting in their bank account waiting to be spent at the fertility clinic. It wasn't money that they could get easily, and people were reduced. I mean, we've seen people selling possessions to pay for IVF. You know, it's just awful, really. And if you can't reduce the cost, what you can do is make it as clear as possible to patients from the very outset what they might be looking at. What's the average cost for a patient in the clinic, not how much is it without half the things they're going to need.
Thank you.
Okay, so before we go to 10 minutes coffee break, as I have to keep an eye on the time, there is here at the Q&A questions to Kate. According to your experience, is it true that fertility patients tend to be more demanding and are more challenging to be managed?
But I actually think completely opposite. I mean, I'm sure that you've all had experiences of really, you know, patients who can be quite challenging. That's often because they're upset and anxious. And I think the more the atmosphere in the clinic is one that is not supportive, the more difficult patients can be, because the less, if you don't feel supported, you do inevitably feel more anxious about things. But what I find really interesting is the kind of huge power imbalance when a patient comes to a clinic. You know, the staff in the clinic can feel almost godlike to them. They have the capacity to change their lives, to give them a child or not give them a child. And that power imbalance is huge. And what we see far more than patients being difficult and challenging is people saying to us, oh, you know, normally in my life, I'm a really confident person, but I went to the clinic and I just sort of turned into a mouse and did everything that they told me. And I think, in fact, that's far more common than patients being really difficult and challenging. And I think if all your patients are becoming very difficult and challenging, you need to look at your service.
Well, I think that was a good final word for this Q&A session. And we shall take now a 10 minutes coffee break. I think there will be video running through the time. And we shall see you all back in 10 minutes.
Just to say, I've included a link for anybody who's looking to practice in the UK but didn't train in the UK. So I hope that's helpful and answered those two questions. Thank you, Robert.
Okay, fine.
Right, I think hopefully you've all had a good coffee break and I'd like to welcome you to the second session of today's webinar, and it gives me a great deal of pleasure to introduce you to Sue Lee, who is a pharmacist in the United Kingdom based in Leeds currently. I don't mean to make you sound old, Sue, but you've been a pharmacist for 37 years and your most recent role is that of working with basically setting up Stork Fertility, which is now HealthNet Home Care, and you've been doing that for the last 12 years. And I think the interesting thing for me is that you're a registered pharmacist, a superintendent senior pharmacist, and there are many nurses and midwives and nurse practitioners, particularly in the United Kingdom, who have taken the qualification to become prescribers, and you took that course yourself to ensure that you could understand the potential issues that nurses and midwives might have with prescribing. I'm really glad you could be here today on a Friday afternoon, so thank you very much indeed for being able to speak to us today about the key components of medicines management, with it being specifically around fertility clinics. So welcome, Sue. Thank you.
Thanks. Can I just check you can hear me all?
Yeah, absolutely can hear you.
Great.
And as you say, great coordination with the scarf there.
Thank you very much. That was just coincidence. Absolute coincidence. Oh, just bear with me a moment. Right, so yeah, thank you everybody, and thank you Helen for inviting me to share today. As Helen said, I'm Sue and I'm the superintendent pharmacist at a pharmacy company called HealthNet Home Care, and Stork Fertility, as we call it, is a branding under that HealthNet banner. If you're in the UK and you know the Boots shops, you'll know what number 7 is to Boots or Sultan. Stork is that to HealthNet. So the role of superintendent pharmacist is a regulatory title. Let me just click off. It's a bit like the person responsible in an HFEA regulated setting, in that the pharmacy superintendent is accountable for all aspects of the pharmacy standards for their pharmacies. And as Helen said, I've introduced in HealthNet the brand, which started off as a new startup idea, but has now grown to become the largest specialist fertility pharmacy in the UK. And I think I am unique. If anybody knows any other pharmacists and non-medical prescribers, then I'd be pleased to be introduced to them. Anyway, what I hope to do for the rest of my presentation is give you a flavour of our Stork experience and the use of home care for fertility dispensing in the UK. I want to tell you what we found works well, some of the challenges, and some of the ways we as pharmacists can support you and your patients in joined up care. I suspect my presentation will follow on quite nicely from Kate's talk about the patient experience. So I thought it'd be good to start by reminding ourselves just what is meant by medicines management. And this in the purple banner there is the definition that was published by the MHRA in 2004. So medicines management is the clinical, cost-effective and safe use of medicines to ensure patients get the maximum benefit from the medicines they need, while at the same time minimising potential harm. And again, Kate's already alluded to the costs involved for patients with some of these drugs. There's been various guidance published on the subject of medicines management, both by the Royal College of Nursing and the Royal Pharmaceutical Society. And more recently, they've collaborated together on some publications, and you can see the details listed at the bottom there. However, there's extremely little, indeed, if anything, specific on the many nuances of medicines management in a fertility setting. But you could argue the key message from medicines management is generic to us as pharmacists, nurses, healthcare professionals, and it's that crucial patient safety, which we all know must be at the centre of everything we do as healthcare professionals. So what is it that makes a fertility setting special or different when it comes to medicines management? Well, for starters, patients find themselves for a short period of time self-administering what can be a whole cocktail of medicines. This usually involves far more injectable medicines than any other type of patient would be sent home with to manage alone. And to add to the complexity, the timing of the taking and injecting of these medicines, they're told, can be crucial to the success of their treatment, and it's essential they adhere fully to the protocol they've been given. We're not just talking here about paracetamol and aspirin, or even an antibiotic they might have heard of. All the medicines are unfamiliar. The dose they take might not match the patient information leaflet. And gosh, some of them have to be stored in the fridge. More of that later. Then once they get started and visit the clinic for scans and reviews, the protocol and the dose can change. Plus at the start, nobody knows quite how much is needed or for how long they'll be injecting. So this slide here in this list just summarises much of these challenges and more. Best practice says ideally different healthcare professionals should be responsible for the prescribing, the dispensing and the administering of medicines. And this, of course, gives the maximum number of pairs of eyes on a patient's medicine to check they're absolutely correct before they're handed to the patient or put into a person's body. Using a fertility home care pharmacy supports this way of working. The clinics we work with are all pleased to just have to worry about doing the prescribing. They're relieved of having to concern themselves with holding clinic medicine stock other than for a few bare essential items for genuine emergencies. This means nurses' time is not taken up with counting and rotating stock, monitoring expiry dates, checking temperatures, and keeping copious records of prescriptions and what's been dispensed and given to who and when and by who. The patients like it too, because they don't have to wait around in clinic to be handed their medicines and then worry how long it'll take to get home and get their precious cargo back into a fridge. If a patient needs a top-up of a medicine, that too can be dealt with by us. The prescription can be sent to our pharmacy. One like ours can receive it electronically. And the next thing the patient knows is when they get a text message inviting them to select the day and time they'd like to take delivery, which can be as soon as the next morning. And they don't have to leave the comfort of their home. And our service is nationwide. But at Stork, we recognise too that dispensing from clinic is sometimes essential to get a patient started on a particular medicine. Maybe there's early signs of OHSS or something like that, or to help someone mid-treatment who's messed up mixing or dropped or broken a vial. So we at Stork, appreciating that need as well, offer the benefit of a one-stop service for all medicines needs, where you can send to us prescriptions for individual named patients, but also order clinic stock. And to be able to undertake both these activities, the pharmacy has to be registered with the General Pharmaceutical Council to dispense and also hold a wholesale distribution authorisation with the MHRA to allow us to send you clinic stock. Oops, just going to go back one. Trying very hard to go back. There we go. What are the other benefits we found in the UK of using the specialist home care pharmacy model in the dispensing of medicines? Well, we can be fast and responsive. Menstrual cycles can be frustratingly unpredictable. In my pharmacy, we set a deadline of 2 p.m, and so long as we've received a prescription by then, we can offer a next day delivery to the patient who can choose the most convenient delivery location, be that work, home, a family member, or a neighbour. We usually have all the medicines in stock and keep them in large number. Patients obtaining their medicines via home care can be sure of receiving a sharp spin every time and everything else they need to manage their treatment. This contrasts with other ladies who may think shopping around and taking their prescription to a local community or supermarket pharmacy will save them a few pounds here or there. But the price they pay for this is firstly, that it's not always cheaper. And secondly, that the pharmacy staff in the local pharmacy are not familiar with the medicines, may not have them immediately in stock, and are far less likely to know what else is needed to be able to self-administer, say, 0.5 ml of buserelin daily. Our pharmacists, in contrast, deal with hundreds of prescriptions for fertility treatment medicines every day, and so are very familiar with different presentations, doses, and everything else, what comes with an applicator, what doesn't, which ancillary items are required. We don't just provide the supply service, but we're on hand, including on Saturdays, to take calls from patients and give pharmaceutical advice. The pharmacists are understanding and sympathetic, often able to tell just by viewing a prescription the different types of patient or couple, or an egg donor, a single female, an older woman using egg donation, a same-sex couple with both needing medicines for different stages of their planned treatment pathway. Our staff on the telephone too are specially trained. They learn that a down-regulated lady can be very anxious, occasionally tearful, and at times a tad irrational, but that's okay. It's not them, it's the medicine talking. And the role of our staff is to handle the situation as sensitively as possible. We teach them that before we let them anywhere near incoming phone calls. For some strange reason, the reaction of a lot of women when they get their drugs is to turn their fridges up. This is never good advice, as it risks the medicines becoming too cold. So the advice we try to give them is, if your milk and butter are keeping just fine in your fridge, your medicines will be just fine too, in the same environment with the same setting. Our walk-in cold stores are similar in size to what you might expect back shop in a large supermarket or to be used by a butcher or a fishmonger. It's much easier to maintain a steady temperature in such large spaces than in the usual upright under-counter fridges. And what's more, we use multiple temperature recording probes throughout our medicine storage areas that take readings every 10 minutes, 24/7, 365 days a year. And I and my colleagues are on call out. We have a generator too, so the storage environment in home care pharmacies can be considered optimal and best practice medicines management for fertility drugs. Then, because the fertility service is part of a larger and wider overnight pharmacy delivery service, we have our own specialist fleet of delivery vans, and they're all dual chamber and temperature controlled. So that means there's one compartment set at the front as a fridge temperature range, and the second, completely separate and sealed, is controlled between 15 and 25 degrees centigrade, the usual storage requirements for most ambient medicines. So this means even on the hottest summer day, both you and your patients can be assured their precious medicines have been carried right to their doorstep in the manufacturer's recommended conditions. When it comes to ancillaries, we've worked over the years to develop a suite of kits. Our IT system is programmed to know if, say, a patient is prescribed 14 vials of progesterone, they'll need 14 drawing up needles and 14 admin needles and 14 alcohol wipes, perhaps. So these will automatically be added onto the order as 14 progesterone kits, and each is a little clear labelled bag containing what is needed for a single injection. Patients seem to appreciate these, and it helps to clarify things in what is a very difficult time for them. It's been an interesting time to see how practice has evolved and changed as a result of the pandemic. And I was interested to hear Kate's comment about portals and the impersonal element that comes, because when we started out, ladies always attended a clinic appointment for a face-to-face injection teach to be shown what to do with all their various medicines. It can be really quite a lot to take in. But now we're finding many of the manufacturers have created videos and websites for their products, Where these don't exist, clinics have recorded their own online teaching videos and posted on their websites. Patients are pointed to these videos in the first instance, which does have the advantage of them being able to watch over and over again and at any time to their convenience. But they remain free to call a nurse or the pharmacy if they're left with any outstanding questions. And we're also able to signpost patients to these videos in appropriate circumstances. But it's really important to direct patients to appropriate and approved manufacturer sites, as there are also less helpful videos emerging on YouTube and elsewhere on social media, where other ladies, often anywhere in the world, have made a homemade demonstration video of how they've done their shots in the hope of it being useful to others. Patients should always be warned away from any such material. Much better, increasingly, we're seeing QR codes being used either on the packaging or in the patient materials that accompany products, particularly for the stimulation medicines, that take a user straight to the right web page and the right training. In recent years, biosimilar medicines have become available. The greatest impact has been on the gonadotropins, but there are also biosimilars of low molecular weight heparins and some other products. When the original Folitropin Alpha brand no longer had patent exclusivity, it made way for other manufacturers to enter the market. They can't do anything to make the molecule different. After all, the aim is to be as similar as possible to the originator medicine. So instead, any improvement or bettering is done in the device used to administer. Thus, we now have the same medicine available in single-dose vials, multi-dose vials, pre-filled multi-dose pens, single-use pens, reusable pens that have to be filled with cartridges. Is it any wonder some of our patients feel confused? And our role in yours becomes so important. Oh, I think I've done it again. Clearly the queen of double clicking here. That's it. Oh, and again. Let me see. Yeah. One more. And back again. I thought I'd just dally a while to speak for a few minutes about what for us in the UK are controlled drugs. These are products with a higher level of control and security than the ordinary prescription medicines because they have a potential for misuse. And because the HFEA in the UK make particular reference to these in their annual report for 2022-23. The inspections of clinics look closely at the management of controlled drugs. And the ones you probably tend to think of as controlled drugs are the ones that are used by the anaesthetist for mild sedation during egg collection. But do you all know that the human chorionic gonadotropin injection used for trigger or the recombinant equivalent are also lower level Schedule 4 controlled drugs? There's unfortunately a market for the misuse of such products as a weight reducing or performance enhancing agent, hence their designation as controlled drugs. I don't think it was ever intended, the law, to catch the fertility industry, but it does. So in the UK, it's the Misuse of Drugs Act which controls the management and distribution of controlled drugs. So on top of the registration and licenses I mentioned earlier, my pharmacy has to hold a license from the Home Office, allowing us to wholesale controlled drugs. And under that license, we can supply clinics with these medicines for clinic stock and for use by your anaesthetist. But primarily as a result of the Dr. Harold Shipman case many years ago now, there are special forms to order on, and those doctors who sign these orders have to quote their special CD prescriber code that they must obtain from the local NHS England accountable officer. It's all very difficult for fertility clinics to navigate this pathway and to obtain these medicines in any other way. And there are many hoops they must jump through to obtain their own Home Office licence, which they need to store the drugs. We at Stork are on hand to support all of these requirements and navigate through the red tape So we're just not dispensing medicines, but we really can support you in other aspects of medicines handling. I've supported several clinics on their journey in that respect. Another key area to explore, and where having a friendly local pharmacist can be so helpful, is allergy. Over the course of time, we've been varyingly asked about all of the issues shown here. On most occasions, we made a medical information inquiry to the manufacturer, at least on the first occasion. And now we've built up a bank of knowledge on these matters and can provide more general advice as well, such as lactose is often used in tablets and capsules, but it's unlikely to be present in a liquid formulation where one exists. And not all gelatin nowadays is of animal origin, so ladies for whom that's important don't have to worry to the same extent. And we can help to advise you on which medicines would therefore be appropriate in regards to gelatin. Latex, when found in fertility medicines, is most frequently in the needle cover of a self-injection device or a pen. So what's important to understand is the extent and severity of a patient's allergy in the past. For example, they might be willing to put up with a few days of rash brought on when they eat egg-based products, but someone who carries an adrenaline auto-injector and has had a full-blown anaphylactic reaction to nuts in the past may need to be managed very differently. Ultimately, a medical and prescribing decision rests with the doctor responsible for the patient's care, in discussion with the patient themselves and their treatment. But as pharmacists, we can give support and advice. I'm sure too that all of you, in one way or another, have had to deal with what has been recently a problem, and that's the issue of stock and supply. This seems to be worldwide and is all medicines, has been for a while, but it's particularly impacted the fertility market in recent days. The general shortage of hormone replacement treatment medicines was the first to really impact. And at different times, we've been unable to get estrogen patches and certain brands of estradiol tablets. We've got around matters by encouraging prescribers to write prescriptions generically wherever possible to minimise the inconvenience for all involved and allow we pharmacists to supply whatever we have available at the time that meets the requirements. But for certain groups of medicines, such as progesterone products used for luteal phase support, there are several options, and it's not too difficult to switch. But when on more than one occasion in the last couple of years, buserelin was completely out of stock everywhere, women and prescribers were faced with the unenviable choice of switching to a short protocol or postponing their treatment until such time as the buserelin became available again. I suspect this is another topic some of you would love to discuss and debate with me further, but I do only have 20 minutes. Feel free to put something in the Q&A if you've got more questions on this. So, lastly, this slide just runs through the home care process for dispensing of prescriptions, which is the most widely used model in the UK. Clinics generate and send prescriptions to the pharmacy, usually in the form of a copy by email in the first instance, although our laws require us to go on and receive and store an original wet signed copy in due course in most instances. Some clinics have their own compliant e-signature system that permits prescriptions to be signed and sent to us electronically. We've evolved our own solution too, which generates a truly advanced electronic signature and can be used in place of posting prescriptions. It would be my desire for this approach to be adopted by all clinics and prescribers. Having a trained and experienced pharmacist checking every single prescription gives another final governance safeguard and assurance to both patient and prescriber. Anomalies are picked up and sometimes errors averted before they reach the patient. And the use of technology such as SMS text messaging and patient portals allows patients to book their deliveries very discreetly, even when at work. They're able to see what they'll be receiving in advance and have welcomed this way of interacting with us. So long as they've booked by 4 p.m, they can receive a delivery the next working day. Being able to have their medicines delivered to their door in refrigerated vehicles to pop straight into their own fridge, and with all the information and additional ancillaries they need, is very reassuring for patients and gives them a lot of peace of mind as to what is otherwise a very stressful time. Overall, it's a real privilege to be working with many of you to support your patients as we specialist home care pharmacists do. And I very much hope the mutual team working between doctors, nurses and pharmacists in this manner will continue to grow and flourish in the fertility setting. Oh, gone one too far still. Thank you very much. If you have got any questions, I will be around for the Q&A and I'll be pleased to answer them then.
Well, thank you very much, Sue. It was really very interesting, and I think I've seen already a couple of questions in the chat for you, so we shall come back a little bit later and try to answer those questions as well. But thank you very much for this very interesting presentation. And now it's my great pleasure to introduce you to a good friend of mine, Tim Child. Tim is Associate Professor of Reproductive Medicine in the University of Oxford, and he's also Chief Medical Officer at Apricity Fertility. He's on the board of the HFEA, where he also chairs the committee responsible for assessing future developments in assisted reproduction. And finally, he is also the chair of the trustees of the new charity in the UK, the so-called Fertility Alliance. So he is the perfect person to present to us the presentation on novel techniques improving medically assisted reproduction outcomes. So Tim, the stage is yours.
First of all, thank you, Robert, for the kind introduction, and also thank you to Helen, Val and others for the kind invite to speak to you all today. It's a wonder of COVID, isn't it? Pre-COVID, there's no way I'd have been sitting here at home in Oxford talking to hundreds of people, hundreds of nurses. Before we get into that, I was really interested by the presentations earlier on as well in terms of the nursing role. I mean, I've worked in Oxford for nearly 30 years, and we've always had a very, very extended nursing role in Oxford. And in fact, when I started, all of the embryo transfers were done by nurses, and doctors didn't really get a look in, which I think was maybe a bit too far one way. But still at the moment in the Oxford IVF unit, when there's 3,000 embryo transfers per year, the majority are done by nurses, and the training for the new doctors coming in is done by nurses as well. So I'm an absolute proponent of the, well, the word advanced isn't the right thing, but an extended nursing role within infertility. Anyhow, I better move on to my presentation. So let's double click. Here we go. So I've been asked to speak on novel techniques, and as has been mentioned, I've been based in Oxford for about 30 years or so, but I'm very much a clinical hands-on doctor. But from the HFEA perspective, wearing my HFEA hat, I am involved in looking at the regulatory side of new things coming in, and that's what I really want to focus on at the moment. And of course, I'd be very happy to take talks afterwards. If any of you want to connect with me, then it's at Dr. Tim Child down there is please how you can connect with me. So let's first of all think about the scenario where a patient has had, and they're talking to you as a nurse, a 35-year-old woman with unexplained infertility. So patent tubes, sperm is fine, ovulatory, and one failed IVF cycle. And her partner come in and say, well, you know, it hasn't worked. I'm 35. I thought this was going to work. It hasn't worked. Why hasn't it worked? And I've been Googling away. I've been looking at Dr. Google online, and I've heard about these things, about these newer techniques, assisted hatching, endometrial receptivity testing, endometrial scratching, embryo glue, all the immune tests that are available out there, steroids, intralipids, intravenous immunoglobulins. How about genetic testing of embryos, PGTA? I've heard there's a new way of doing PGTA, and of course, time-lapse. you know, which of these things shall I do? So what I thought would be helpful will be, first of all, just to look at some of these. Now, in the UK, there was a big furore, so there was a bit of an outcry around about 2016 as regards things called add-ons. So that everything I've mentioned to you so far is considered an add-on. And what was happening, if I go back to IVF before about 10 years ago, IVF generally, in the UK at least, and I've worked in a number of countries in Europe, was very straightforward. So people would come in, have ovarian stimulation, an egg collection, IVF or ICSI, culture the embryos for 3 to 5 days, do an embryo transfer, freeze any spare embryos, and that was it. It was a very vanilla, straightforward IVF cycle. And then what happened? Patients started asking about these other things. And I remember the first patient coming in, I remember her asking about intralipids. And I was thinking, I haven't even heard of intralipids, and me having to Google what it was. And there was a concern in the UK that clinics were selling and proposing add-ons, things that could be added onto an IVF cycle for cost, for money, for profit, where possibly there was no benefit. And so there was an undercover BBC program on this. There was research papers, and you can see a couple of them here, one published in the BMJ, looking at add-ons. And the UK government, via the HFEA, asked the HFEA to look at add-ons in more detail. And the definition that the HFEA, which is the regulator of IVF in the UK, and I'm on the board of the HFEA, the definition of add-ons are optional, non-essential treatments that are used in addition to a standard IVF or IUI cycle. That will mainly be focusing on IVF. And it was pointed out that usually the evidence for increased success of add-ons is often absent, so it's just not there, or it's very limited, and they nearly always cost extra. So the HFEA came in with a traffic light system, and it was a red, green, or amber, and it was based on randomized controlled trials. So the committee that I now chair, but this was before I took over the chairing, used randomized controlled trials to assess add-ons and to decide whether the add-on increases the live birth rate for most IVF patients. So not specific age groups or implantation failure, it's should most IVF patients have this add-on, and does it increase the live birth rate? And green meant that yes, this add-on increases the live birth rate. Basically, everyone should have it. Amber means it's conflicting. Maybe there are no studies that have ever been done, or there are studies, but some say yes, some say no, so we don't know. And red means that the add-on should not be used. Either it definitely does not help you, or maybe it's dangerous. And this was the first time that this had been done, really, as far as we were aware, around the world by a regulatory authority. And you can see the add-ons page. If you go at the bottom there, hfea.gov.uk, this is all freely available. And in my previous role, I was medical director of 20 clinics across 6 countries in Europe. And our Polish clinics actually translated this and used it for their patients because they found it helpful to show that this was a non-commercial view of add-ons. And the committee that puts it together is multidisciplinary, with nurses, embryologists, medical doctors, scientists, lay people, statisticians, all deciding. Now, this system here, the 3-color system, the traffic light system, was great, but it was a bit basic. So what we've done is we've moved now to a more of a subtle system. And if you look, green is still green. So green means that this add-on should be used, it improves the outcome. Black means that studies show it does not work. So it should not be used because we know it doesn't work. Red means studies show it makes things worse, so it lowers your outcome, or maybe there are safety concerns about it. Amber and grey mean that we don't know. But amber, the plus minus, means that some studies say yes, some studies say no. So you could have a really good quality study saying, yes, you should do it, and a really good quality study saying, no, you should not do it. What do you do? They're conflicting. So that's amber. Or you could have grey. Grey means you really don't know because there are just no studies, and intralipids is a perfect example. So intralipids, we really don't know at all. Now, I also mentioned that the previous way of doing the add-on system was only randomized trials. And the problem with that is there are lots of areas where there are not any randomized trials. So we decided to have a system whereby if there are no randomized controlled trials, then we go down to the next level of evidence, which is cohort studies. But just good quality cohort studies to at least try and increase the evidence base. We also decided to look at, rather than does the add-on work in most fertility patients, which is useful, but it's not overly helpful, because if you have an older patient or a couple who've had recurrent miscarriage or recurrent implantation failure, they're not the same as most. So we also looked at specific patient groups, and we also looked at more outcomes. So rather than just live birth as the outcome, we looked at, for instance, miscarriage rate of ovarian hyperstimulation syndrome, all sorts of different outcomes like that, time to pregnancy, for example. So it's much more subtle. And again, if you go to the HFEA site, hfea.gov.uk, and you put in the search button, you put add-ons, it will come up with this page here. And it's aimed at patients, okay? So obviously many people in the sector, nurses, doctors, embryologists also use it, but the language and the aim of this is on patients. So, and if the patient decides to look at assisted hatching and clicks on the line there for assisted hatching, it will go through and all of the minutes are there, the discussion is there, the research papers are there that were used to help decide on giving assisted hatching grey, which means there really are no studies. Everything is there. And so it's very, very transparent. And there, if we look down through here, so we have assisted, and this is, does this add-on improve the live birth rate for most fertility patients? So assisted hatching, we don't know because there are no studies of any quality at all. Elective freeze-all, some say yes, some say no. Endometrial receptivity testing actually lowers your live birth rate if you use it. And that is why in the UK now, I think it's pretty unusual to use it. Endometrial scratching, amber, and embryo glue, amber as well. Now, one thing to point out here is that ESHRA have also done their own add-ons work, which came out, this one came out a year ago. The UK HFEA one came out in October 23. And around the same time, a couple of months later, the ESHRA add-ons one came out, and they used a different methodology. I feel maybe it wasn't quite as transparent as this one. You can't click through for all of the minutes of the discussions about why were some people saying that, why were some people saying that. But pleasingly, the results are almost exactly the same. So even though it was different methodology, the results are almost exactly the same, apart from I would say the one which is different, which is embryo glue. So we felt that the studies were still a bit conflicting on embryo glue to say everyone should have it, whereas ESHRA felt that basically everyone should have embryo glue. And I think partly that was because they felt it's quite a cheap thing for a laboratory to buy. The only thing I would say is it might be cheap for a laboratory to buy, but when patients buy it from the clinic, they often pay a lot of money for it. And we felt the evidence wasn't quite there yet. And we also have, in terms of does the add-on improve live birth for most fertility patients, immune tests, intralipids grey, no one knows. We felt that intravenous immunoglobulin and steroids should be red. And that's because there's a lack of studies showing benefit, but also we felt there are dangers. So intravenous immunoglobulin, we felt as a committee, people should not be taking this. There is no benefit and there are risks of taking pooled blood products. And also steroids. Steroids taken in early pregnancy increase the risk of cleft palate of the baby, and through pregnancy increase the risk of gestational diabetes and various other complications. And if there are no proven benefits, why take something with a risk? And you'll see there, the middle one there is PGTA. So should PGTA be used for most fertility patients to improve the live birth rate? We rated it as red because we felt that Again, there are no studies showing that overall it improves the live birth rate, and we felt that there are risks of discarding embryos that may have viability because the test is not 100% accurate. And you'll see time lapse is black, but I'm going to come on to this a bit more now. So as I said, if you then look at the hfva.gov.uk website and you're interested in any of this, here's an example for endometrial scratch. So you'll see here where we've actually split it up. So rather than looking at should this add-on be used for most patients, we've got here the top rating there, the amber, is most patients, but the lower one is patients with recurrent implantation failure, which is often when you hear endometrial scratch being discussed. But for most patients, it's amber because studies we felt are conflicting, because we don't know. But for implantation failure, we also don't know, but it's because no studies have been done at all, as is explained there on the right-hand side. Elective freeze-all cycles. Again, if we're looking at does it improve the live birth rate, for most patients, it's amber because there are some studies that are suggesting that it's worth freezing all of the embryos, letting everything settle down, and then doing a frozen transfer, a month or two later on in terms of improving the live birth rate. But it's amber because some studies say yes, some studies say no for most fertility patients. But it's green in terms of reducing the ovarian hyperstimulation syndrome risk. So definitely a planned freeze-all, even if you do it in most of your IVF patients, not just high-risk ones for OHSS, does appear to reduce the risk of OHSS. Steroids, as I've said, and I'm fully aware that steroids are actually used quite widely in some countries. Again, I was medical director of some clinics in Germany and Austria, where it seemed to me that steroids were used much more widely than we would use in the UK. But again, when we looked at it, should most fertility patients have steroids? No, it's red. How about for reducing miscarriage? It's red. How about for those having immune testing? It's red. Red all the way down. My view is if someone has an underlying immune condition, so some kidney or renal immune condition or serious asthma or something that they need to have steroids for their own general health, of course, absolutely do that. But if a fertility doctor is doing a blood test and you say steroids, personally, I would run a mile away from a fertility doctor prescribing a relative of mine steroids for fertility reasons. I think it's inappropriate. Intralipids, again, very widely used, often for supposed immune conditions, but it's grey. And even if there are studies that are published out there looking at intralipids, the scientific quality of the studies is so poor that you might as well ignore them, because I think, as any of you will know who've tried to get things published, there's a pecking order, there's an order of things with really Nature Medicine at the top and the Lancet, BMJ, New England Journal of Medicine. You go all the way down to journals that probably will accept almost anything that your cat wrote. They're just desperate to get things published. And so some of these things are published in such poor quality journals that really I think they should be ignored. So intralipids, I can't say whether they're beneficial or not. I don't know because there's nothing on it. And that's the HFEA government view. I guess unsurprisingly, intravenous immunoglobulins, it's the same as for steroids, where there's a lack of any proven benefit, whether it's for most patients, miscarriage patients, or those having immune testing. If we don't know that there's a benefit, but we do know that there's a risk of having pooled blood products from thousands of patients, then why take that risk? And I've never in my career prescribed intravenous immunoglobulins, or steroids in fact, for patients without a known, proven, proper medical condition. In fact, even IVIG, I've never prescribed that. Now, PGTA is the interesting one, and this is the one that when I talk to a room full of embryologists, they get very, very excited, or I should probably say upset about this, because I would say in general, not always, but in general, embryologists love PGTA because obviously it's right within their field. They feel that everything is just focused on the embryo. I feel that being doctors and nurses, we take more of a step back view on this and more of a wider view. The question is if a patient is having PGTA and is having an egg collection and blastocyst culture, and you're getting to day 5, what is the benefit of doing PGTA at that point? If she has 5 embryos biopsied and all of them are abnormal, then she's paid for an IVF cycle, blastocyst culture, PGTA, and all the analysis, and she's probably paid 10 to 15,000 euros for all of that. But she hasn't got a baby because she's not having an embryo transfer. And I think sometimes what happens is that people who really push PGTA only look at the success rates per embryo transfer of a normal embryo, a euploid embryo, forgetting all of the patients who haven't made it to that point, but have paid exactly the same money and been through the same treatments. I'm not saying PGTA should never be used, but it needs to be used in the right circumstances. So if we look here, does PGTA improve the chance of having a baby for most fertility patients? The view that we took was red. And if you look in the top right there, you'll see the sections, what's the evidence is underlined for PGTA? Is this add-on safe? It goes into a lot of detail there aimed at patients. But the second one down, it does appear that PGTA does reduce the chance of miscarriage. And obviously it's reducing the chance of miscarriage because you're putting back an embryo where you know the genetics. So the miscarriage rate is probably halved compared to a random embryo going back. But that doesn't necessarily mean you increase the chance of having a baby. Just because you're reducing the chance of miscarriage is not the same as increasing the chance of having a baby, because you're reducing the chance of miscarriage by not putting back some embryos. And then if you look at the bottom bit there, I would say in general nowadays, PGTA is suggested to people who are probably older or who have had recurrent miscarriages, etc. And you'll see here, there's just no studies. And I'm an author on the STAR trial, which is really one of the largest worldwide studies, randomized control studies of PGTA. It was 1,000 patients, and that showed no benefit of PGTA. And it was sponsored by a company that make the kit for PGTA, Illumina. But if you start looking at patients who are older patients, which you probably would think, and logically, that is the group that PGTA might be beneficial for. For older patients, there are no decent randomized controlled trials or even cohort studies. There's just nothing published on it. So you might suggest it to a patient, but we can't say it's definitely beneficial. And then time-lapse. Now, time-lapse I find amazing because time-lapse incubators, again, embryologists absolutely love time-lapse incubators. It's it's toys for the boys and the girls, I think. And they are very good incubators. But do they increase the live birth rate compared to not using time-lapse? And there is no evidence of them. And the companies making time-lapse incubators have managed to sell them into nearly every IVF clinic of a good quality clinic in the world. But there is no evidence of any benefit of time-lapse over non-time-lapse for this. Now, we decided this at the HFEA, as I mentioned, this updated HFEA table came out a year ago. And that was based on studies that came out then. And black means there is evidence that there is no benefit. Okay, there is evidence that there's no benefit. And after we published, so after we published our own HFEA work on this a year ago, there have then been 2 very, very good papers that have come out, randomized controlled trials looking at time-lapse versus non-time-lapse. And this first one published in The Lancet. So The Lancet is probably the 3rd highest quality medical journal that there is. And this was a UK randomized controlled trial. 1,575 patients, so a massive trial, were randomized to have EmbryoScope Plus with using the algorithm, or EmbryoScope without the algorithm, choosing the embryo, or just standard culture. And it really showed absolutely no benefit at all. If you look at the bottom there, time-lapse imaging with the algorithm choosing the embryo was a 33.7% live birth rate. The incubator with the embryologist choosing the embryo was 36%, and standard care in an old-fashioned incubator, 33%. And statistically, these were all the same results. So there was no benefit of either the incubator or the algorithm choosing the embryo. And then an even bigger more important paper came out in Nature, so the top level medical journal. And that was, again, this is from only 3 months ago. So it's very up to date, August 2024. And this was a study where time-lapse incubators were used, but the patients were randomized to have AI in the time-lapse incubator choose the embryo versus an embryologist choosing the embryo. And the live birth rate was 39.8% with AI, all the fancy stuff, versus 43% without AI, with the embryologist choosing the embryo. So there was no difference. And if you go to the frozen embryo cycles, the success rate was better with the embryologist choosing it as opposed to the AI system. And the only improvement in the using AI to choose the embryos was you saved 3 minutes per patient, not per embryo, 3 minutes per patient, and that was it. So both of these papers in Nature Medicine and also the Lancet absolutely confirmed that it has been proven that there is no benefit in using time-lapse to increase the live birth rate per patient. Now, just coming to the end here, what's coming around the corner? I've shown you things that are out there that are being used, that are being suggested to patients. There are other add-ons there as well. I haven't got time in 20 minutes to cover all of this. But what is around the corner? Well, something which is coming is in vitro derived gametes. And as it says on the right-hand side, turning stem cells into human eggs. Essentially, there are 3 companies in the world, there are 2 in the States and 1 in Japan, that are investing, look at the bottom right, investing millions and millions and millions of dollars into this, because this is the holy grail of fertility. As you'll be aware, women are born with 2 or 3 million eggs in their ovaries. The numbers of eggs goes down over time and the quality goes down over time. And so what these companies are doing are looking to see, can we turn cells from the body into human eggs? Can you take a mouth swab and take away thousands of skin cells from inside the mouth, or a blood test, and from those cells that are there, turn them into human eggs? And in other species, you can, and there have been babies in other species born from doing this, from making in vitro derived eggs and in vitro derived sperm as well. And when you talk to these companies, they will say that within 2 to 3 years, this will be commercially available. Now, from an HFEA perspective, with my HFEA hat on, we had a meeting about this 2 or 3 weeks ago, because this is a big thing. Because these are not eggs or sperm, because they're coming from different cells. And at the moment, they fall outside of the law, because the law talks about eggs from the ovaries, sperm from the testes, not eggs from a mouth or blood test. So these are not regulated at the moment. And the second question is, how safe are they? If you make what looks like a human egg from a blood test, is the DNA exactly the same as a human egg? If you make a baby from that egg, what's the safety? How close is that DNA to a proper egg? Because all of us, as we get older, there are things that happen to our DNA. Our DNA changes, epigenetics, all sorts of issues. So how do you regulate this? If you make a baby from an in vitro derived egg and an in vitro derived sperm, that is completely outside of the regulatory environment at the moment. And the final thing to say there, that from a man, because men have XY, it has been shown you can make an egg and a sperm from male cells, okay? Because the X can be split off and then you can make eggs from that. So this is a brave new world, which literally is just around the corner. Now, I said that the companies that are fundraising for this and are doing loads of research are talking about it being available in 2 to 3 years' time. When you talk to academic scientists, they don't believe that. They think it's more like 10 years or so, but who knows who's right and who knows who is wrong. So looking at that 35-year-old woman with unexplained infertility and 1 failed fresh IVF cycle, and she comes in after her personal consultation with Dr. Google and says, well, I've read about all these things. I've looked at these amazing clinic websites. This is what I would like to do. And you can say, well, I've looked at the HFEA website in terms of add-ons, which is aimed at patients. I've looked at the ESHRA add-ons, which is aimed at I would say, clinical staff rather than patients. What does it show? Well, assisted hatching, we don't know. Endometrial receptivity testing, the most recent studies show that if you do that, you lower your live birth rate. You don't make it better or leave it the same. Scratching, glue, we don't know. Steroids, our view is don't do it. Intralipids, don't know. IVIG, don't do it. PGTA, don't do it. Time lapse, don't do it. So sadly, most of it is a don't do it, or it doesn't appear to help. Then it's up to the patient to decide. So if they really want to push for something, they can have that discussion. Again, my view is the stuff that's there on red, I would not be happy to go along with, because I think it's making things worse for them. Now, one thing to say is I'm very keen on increasing the amount of awareness of patients and staff out there for some of this stuff. There's a lot of things that happen that is very commercialized far too early. And so even though I'm not in the right age range for this at all, at the beginning of the year, I started an Instagram page, and every week I do an Instagram live, and patients or staff can type questions in. And I did one last night, or 2 nights ago, I think. I published those, all this sort of stuff here. So if you're interested, please follow me on that. And as I said, you can please connect with me on LinkedIn or Instagram or whatever, at Dr. Tim Childs there. And this is a picture of Oxford where I work. In the middle there, the domed building in the middle is called the Radcliffe Camera. It's a library. It's where the students in Oxford sit and study every day, looking out of the windows, and I think what an amazing place for them to study. And anyway, I've enjoyed talking to you, and I'm happy to take any questions. Thank you.
Thank you very much. That was inspiring, as always, Tim. And it takes me back to, I think, my second BFS meeting, which was held in Oxford, and they put us up in student halls accommodation. That was an experience, I have to say.
I remember that.
But yes, thank you very much for that. We'll come back to questions with Tim at the end of our last session. And for that, I'm delighted to welcome Jennifer Ulyat, who is a senior advanced nurse practitioner at the Assisted Reproduction Unit in Dundee in the UK. She's been a member of the Ninewells Assisted Conception Unit for 10 years, and her post was initially set up as a standalone role to introduce and develop a new service for nurse sedation, which is now, I'm really proud to say, is completely nurse-led. And thanks to Tim for advocating again for nurses and the extended role. Again, I remember Debbie Barber from Oxford being, I think, one of the first UK nurses to advocate nurses doing embryo transfer, and wrote a paper in Human Fertility, I think, in 2005. So Jen has been awarded the Nursing Prize for her presentations on her work at Fertility 2015 and 2021. And I think it was only when I was doing a bit of work with Jen a couple of years ago, looking at job descriptions and salary, etc., that I realised just the extensive knowledge, skills and competency that goes into providing a nurse sedation service. So I'm delighted to hand over to Jen.
Thanks, Val. Okay. Okay. Hi, everybody. My name is Jennifer Ulyat. I'm a fertility nurse and the Senior Advanced Nurse Practitioner for Sedation within the Assisted Conception Unit of Ninewells Hospital. I've been asked to speak to you today about the evolution of the specialist nurse and have we gone too far? So the aims of the talk today is to discuss how the specialist role came about, to look at what's so special about a specialist nurse. And I'm going to tell you a bit about my own experience about introducing a new service and a new way of working within my own department, and we're going to have a look at a case study. So the evolution of the specialist nurse. So the earliest publications that I was able to find looked at 1960, 1970, and the specialist nurse came about as a result of nurses who had worked within a specialist area for a period of time who showed a specialist aptitude. They were educated under an almost apprenticeship type system, whereby they were taken under the wing of the consultant. They were educated to a high level. They had a very clear understanding about the the illnesses, the disease pathways, the treatment, the impact of the illnesses on their patients. And they were able to help assist the care of their patients through helping planning their care, looking at options that were available, discussing options with patients, and doing it with a caring and attentive manner with the patients. They were also taught to do specialist skills and tasks within their field that were prevalent to their patient group. And due to their experience within this area and their willingness to stay within their specialist field, they not only learned these skills, they perfected their skills and became experts within their own clinical areas. More recently, there has been almost an explosion within with specialist nurses. They have come up within many different guises with many different titles. We have ANPs, consultants, physician's assistants. I'm sure you can all add to that list. And this increase in specialist nurses has come as a result of the reduction in medical clinical hours. And this is as a result of the Working Time Directive, European Working Time Directive, and because of the change in the modernising medical careers. And we've had a reduction in the number of junior house officers, senior house officers, or FY1s, and trainees within the wards. And there was a focus on how to fill this clinical gap with a cost-effective way of providing specialist care. And as a result, there has been a massive increase in the number of specialist nurses working clinically within their own specialist area. But what has one of the great advantages of that is that there's been massive development in the number of advanced nursing qualifications and the number of courses, standalone courses that have been available to nurses within their specialist field. These courses, as you've heard before from the talks today, can go from standalone modules to degree level, to master's level, and even further, which I just think is an exciting opportunity for nurses to show the level of clinical excellence and expertise they have, their level of clinical knowledge, and be able to evidence it with specialist qualifications. So what is so special about a specialist nurse? Well, this is just a list that I was able to put together just looking at my own workplace and having done courses and speaking to other nurses, nurse specialists within the field. I'm sure every one of you could add extra to this list, but what this list essentially shows is that nurses have an expert level of knowledge. They are able to work alongside their consultants and their peers to help prescribe treatments, to help assess treatment, to help communicate with patients, and to make sure that the appropriate treatment is prescribed for each of the patients. They have excellent skills and skills in their specialist field. We have nurses that are doing scanning, IUIs, embryo transfer, even oocyte retrieval, and my own team who do sedation. And we are specific to the fertility group. And because, again, I can't reiterate this strongly enough, we don't move about very much as specialist nurses. We find a field that we are passionate about, and we develop ourselves, and we stay and we evolve with the service. So we're able to speak to our patients about changes that are happening within fertility, things that they are picking up on the internet. We're there at the grassroots levels of change within our specialist field, and we have the clinical knowledge and expertise to be able to communicate in a way that patients understand what all these changes are and the impact it would have on their treatment. Therefore, we're able to provide specialist care to our patients to ensure that they're getting individualized and appropriate attention. So nursing is changing, and as a result of this, we need to be able to adapt with changing. The specialist nursing role, as I've explained, is becoming more and more prevalent. And to be able to change with nursing, we need to be able to consider how we would implement changes within our own departments. I'm sure every single one of you can think about something within your own department that you think can be improved on. And what I'm going to do is share my experience of implementing a service so that you can maybe take my experience and start looking at these changes that you think you would like to create within your own department and have a better understanding of how to move forward with them. So I was employed in 2013 at a very cost-effective 15 hours a week to replace the anaesthetic team. They no longer had the capacity to provide sedation for fertility procedures. And they'd looked at many options available to them. But one of the things that they were most keen on is that we didn't change the method of which we were given sedation. The anaesthetic team were keen, and a fertility team were keen that we stuck to the same drugs and regime that we'd been using previously. And that included administering midazolam, propofol, and alfentanil for sedation and pain through the procedure. This concept was risk assessed by our governance team. And as I said, I was employed a very cost-effective 15 hours because nobody really knew if this was actually going to work. One of the first obstacles I came across, however, is that not all of the anaesthetic community were on board with the administration of propofol for sedation by anyone who was not an anaesthetist. It wasn't exclusive to nurses, it was all physicians that were not anaesthetists. So I had there was many articles published with similar viewpoints, and I had quite a big obstacle to jump across before I even got started. So one of the things I did was look at exactly the standard of work that the anaesthetic team were providing. I looked at all the protocols, pathways, governance, policies that were available, and looked at how the anaesthetic team had applied them within their own area. And then I looked at how we can make them even safer. I needed to ensure that using the anaesthetic guidelines for administration of sedation using propofol was as safe as I possibly could. I was determined not to let this fail at the first hurdle, and I created a service that reflected the safety of the anaesthetic team, but created it with parameters that made it even safer for nurses. The next obstacle I came across was the consensus from some of the nursing team, not just in my own department, but throughout nursing. That's not a nursing job. That was one of the things that was communicated with me very early doors when I was employed. I think we've all heard that too often. That's not a nursing job. And when I first qualified, so many things that we take as standard treatments for nurses, IV drug administration, cannulation, taking an ECG wasn't considered a nursing job. And therefore, you know, the way I look at it's not a nursing job is, well, can we take this? Is it essential for nurses to do this? And can we take this role in this job, and can we make it safe for nurses to do? If you look at nursing students now, they're qualified with far more technical skills than say even 20 years ago. So just because it's not been a nursing job before doesn't mean that it shouldn't be a nursing job in the future. However, we are not doctors. As much as I'd like to think I can intubate a bit better than my daughter can in this picture, I'm as qualified as she is to intubate. So when creating a service or making a change within your area, you need to first and foremost consider the fact that we're nursing staff. We need to ensure that any changes that we're making within the department are going to supplement our nursing skills. When I'm teaching new sedation nurses how to perform sedation within our department, I talk about the effects of the drug and I talk about the side effects of the drugs. But I mostly talk about how we are not to use drugs within our department to replace what we do as nurses. Our gold standard is conscious sedation, therefore our patients are able to communicate and talk to us through the whole procedure. At no point should they ever be asleep. Therefore, it's so important that we use our nursing skills to communicate, to help our patients cope with the procedure, and we use the drugs to assist that process. when you're making any sort of change at the core of what you're doing, you need to consider whether or not this is going to benefit your nursing skills, whether it's going to benefit you, your career and your department through the changes within the you're making through your nursing team. And if it's not going to benefit you as a nurse, then I don't see the point in doing it. You know, the core of everything that we're doing as nurses is that we provide good nursing care to our patient and that we make it safe. You're going to come across difficulties in making any change in your department. You're going to come between a rock and a hard place, essentially. This isn't a failure. This doesn't mean that you don't progress. This just means that you show your adaptability. You look at what the difficulty is and you look at different pathways. We all like to get from A to B using the motorway so we can get there as quick as possible. But we've often having to travel down the A roads, and the journey itself is sometimes much more beneficial. So if we consider where we want to be and how we want to get there, we need to be able to adapt our practice and look at different options that are available to us. And sometimes the end result will be that you've got a better service because you've considered lots of different variables and you have failed frequently along the way. So when things have become difficult, never give up on implementing your change. Just look at a different pathway. So one of the ways of assisting that process of looking for a different pathway is research, audit, looking at safety and patient satisfaction. So when you're researching your topic, read absolutely everything that's available to you. Speak to the specialists, even those specialists that are not interested in assisting you setting up the service, those that are actually considering barriers to you doing so, because these difficulties, these barriers that they put in place, they might actually be the key to making your change successful. Any change you make, you should definitely audit. You know, whether it's been successful or unsuccessful, you should definitely show evidence of the changes and the outcomes of these changes. And then you should feed it back to everyone involved, including when things haven't gone right. Get feedback from them, from your data, have conversations. Use that research and the data that you've had in these conversations to bring all the information together to improve what you're doing in the change. And safety has to be key to what you're doing. So no matter what you're doing, look at things that have gone wrong elsewhere. Other people may have tried to implement these changes that you're thinking about, and they may find that there has been difficulty with safety, and use their experience to help build your treatment pathway or your change of practice to make sure that you are keeping your patients safe and cared for. And finally, patient satisfaction. It's so essential that we get feedback from patients. They're the reason we're doing whatever we're doing. So have conversations with them, discuss what their experiences are, and then gather that information to look at a way of bringing numbers together, showing that things are working, getting statements from patients, showing that they're happy or they're not happy. And don't be afraid to share bad patient experiences, because all that's going to do, yet again, is going to teach yourself and it's going to teach other people how to improve what they're doing, which is vital, because if it's not working for a patient, then we need to make sure that it does in the future and that no other patients should have a negative experience within your own care. So what are the benefits to specialist nursing? Well, there's consistency, as I referred earlier. Once we become specialists in an area, we tend not to move about very much. So I have been within my area for since 2013, and I have consistently built on my skills as a sedation nurse and a fertility nurse. And I've personally performed 1,700 sedation cases without error, without any complications. So there is a consistency in the fact that I am building on that first learning that I had all those years ago, and able to pass on that learning and that education to others. Time-wise, I have much more availability and time for patients. We run a pre-assessment clinic twice a week for our patients, and we have half an hour with each patient looking at their physical, ability to cope with sedation, but also being able to optimize them, so that if there is something that we need to be looking at that's going to benefit their pregnancy as well as their treatment, that we have time to do that. And because I'm not pulled to different clinics or to cover different lists, I've got the ability to ensure that I'm able to follow up on patients and make sure that they are optimizing themselves for their treatment and their pregnancy. We're evolving with the service because we are in an area for a longer period of time. We will keep evolving with the service with all the changes that are happening. And fertility treatment, assisted reproductive treatments are constantly changing with new ideas and new concepts. And even in the short 10 years that I've been within fertility, there has been big leaps and changes within my own clinical area. And because you're there at grassroots levels, you're able to communicate that with your patient group, and you're able to communicate it in a way that they would fully understand. We know the team. So if I come across a patient who has a specific question or they have a specific difficulty with the treatment that they're going to come through, I know who has specialist interests in these fields. I know who is able to treat this patient with their specific concerns. I know who to speak to if it's myself that's relaying the information, to make sure that I have the most up-to-date information. So knowing your team and knowing who is available to assist you in your patient care will help make sure that the right information is being passed along to your patients. And I know my patients and I know their families. As a result, we're able to care for them as a whole. We're not just looking at the patient, we're not just looking at their infertility, and we're not just looking at their assisted reproductive treatments. We're looking at them and what they need to be able to progress with their treatment and to be able to cope with their treatment and hopefully even thrive through their treatment. And we're able to take that information and individualize their care. I know different patient groups and different patients who have specific concerns and difficulties within this area. And I'm able to communicate with my sedation team what different patients need and what different inputs they're requiring. So I'm able to individualize the sedation care for each patient that we're seeing. So one of the case studies is the case study I'm going to look at is a change that we have most recently made within our department that one of my sedation team has presented on fairly recently. It was a few years ago, and we had a young lady who was coming through for treatment. She had coped with all of her scans. She had coped with the procedures up to that point, and she came through to us. We didn't have huge amounts of concern. We thought it would be a straightforward case. And this lady, unfortunately, through her sedation, relived on repeat a serious sexual assault that she had experienced in her youth. It was quite distressing for the whole team, and it was quite distressing for those of us that were providing sedation. But when we went to speak to her afterwards, her concern was not that she wasn't getting the right help. She was getting the right help. She was getting counselling. She'd had a lot of input. She had comforted herself with how she was dealing with this. But what her concern was that she thought maybe the feeling of intoxication during her sedation might have triggered her into repeating the thought process of her sexual assault. So although she was very amenable to the conversation, we realised that we didn't have a clue what was happening with this patient beforehand, and we needed to make sure that we were never in this situation again, or we never allowed a patient to be in this situation again. So we did a lot of research on the subject. We had read lots and lots of articles, lots of documents about the prevalence of sexual assault within the UK and especially within Scotland. And without question of doubt, we have treated lots and lots and lots of patients who have had a history of sexual assault that we were unaware of, and therefore we were not caring for this patient group appropriately. So myself and one of the other sedation team, we went on a course to find out a little bit about how this patient group process trauma and what we can do to support them. The course was so enlightening that we organised for the person who ran the course to come into our department to speak to our secretarial staff, our embryology staff, our medical staff, and the rest of the nursing team. And we, as a team, discuss what we can do to better provide for this patient group. Now, within our department for women, the sedation team are as the first port of call for patients. They come into our clinic, they are pre-assessed, and they have their AMH done. And in this pre-assessment, our documentation had only focused on their physical well-being. It looked at any sort of comorbidities that they had, anything that might have caused complications within their sedation. We'd never really looked at anxiety, depression, or their ability to cope with vaginal examinations. And we thought, well, this is the prime opportunity to open up that conversation so that in the early stages of their attendance in the department, we can ensure that we are putting things in place to provide the right care for this patient group. So we added a section to our pre-assessment and we made it quite vague. So we asked, do you have any history of anxiety? Yes or no. Do you have a history of depression? Yes or no. How do you cope with cervical smears? And how do you cope with the speculum being inserted? Very simple conversations. If anybody has answers yes to any of the questions, we inquire about any assistance that they're getting, whether or not they feel that they're getting the right input, whether they're on medication, or whether they need an extra assistance within the department, and we would refer them to our fertility counsellor. We never inquire about whether or not somebody has had a history of sexual assault. That's none of our business unless they want to disclose that to us. But if they have documented that they have difficulty with the insertion of the speculum or with a vaginal examination, we will encourage them to come and speak to a member of the sedation team before they come for treatment, and we'll make an appointment with them. And sometimes within that appointment, what we do is we introduce them to our vaginal scanner so that they can see what it looks like. They know exactly the dimensions of it. They understand the process of how it is used. We've had patients lie fully dressed upon the trolley with their legs in the stirrups, trying to get on and off the bed so that there's comfort in being in control on that process. And we talk to them about their sedation, and we talk to them about the monitoring we use, about the oxygen mask that we use, and about what it would feel like for them to be under sedation and how they want it to be. We even discuss what kind of music they would like to listen to. Every aspect of their care is looked at. And surprisingly, what has resulted is that you would think that you would want to put these patients under a deep level of sedation, but we're not able to provide that for patients. So we've tried different ranges within our own protocol. And what actually works best is not starting the sedation properly until the vaginal probe is in place. And what we have an agreement with our medical staff that if we have patients that have difficulty within this area, that we get them up in lithotomy, we get them prepped and sterile drapes put across them, we're monitoring them, and then we put the vaginal probe in, and then we stop. And that's when we start the sedation, because that control of being able to know that they are not feeling intoxicated, knowing that at any point they're able to stop the probe going in, is really, really important to give this power back to these patients. You know, when they've had episodes of sexual assault, they didn't have power. And then they come through fertility and basically they're handing over the power of their fertility over to us. So we need to grasp hold of any stage that we're able to support them having power and having the ability to take charge of a situation. Once we start the sedation and the vaginal probes in place, the majority of patients cope very, very well. But we tend to keep the sedation rather light and focus on analgesia as the main way of helping them cope. And we spend a lot of time prior to going through theatre discussing what they want to talk about, finding out about them so we can direct the conversation with the patient away from anything that might cause a trauma. One of the other things that we've done is that we've opened up a pathway for patients who wouldn't normally want to disclose information or may feel uncomfortable disclosing information just through an appointment. and that in every bathroom in our department and every private changing room in our department, we have little red stickers. And there's a poster there that says to our patients, if you have something of a sensitive nature that you wish to discuss, please pass the sticker on to any member of the team and they will get somebody appropriate to find you and speak to you in private. So that opens up, again, that gives them control to make a decision about when they want to discuss something or if they want to discuss something. And the whole team, as part of our planning for the care for this patient group, are aware that if they receive a red sticker at any point, that they go to certain members of staff, if possible, our counsellor, to speak to this patient and find out what we can do to support them. So, as you can see, even something as unexpected as one sedation case can change a whole way of treating patients within your own department. And that's why I'm saying, if you have a concept or an idea of how to change something or something you'd like to improve in your own department, don't step away from it, don't shy away from it. Embrace it, research it, and take it to the team, because we're all here for our patient group. We all want to make sure that patients are supported and well cared for. And we're as the nurses in the department, we're going to help pioneer that and push these changes forward. So the future of nursing is changing. I do believe there's going to be more and more specialist nursing posts in the future. There's going to be more and more courses, and we need to be able to evolve with this, and we need to be able to lead the way for our own profession and for our own job satisfaction and for our own patient groups. So what do we need to implement effective change? You need an enthusiast. You need to communicate really well with the team. You need them to understand where you're coming from, what the plan is, and you need to be open to their communication and their ideas and their concerns. You need to be adaptable in your approach to what you have considered normal practice, and you need to evidence what you're doing is having an impact. Patient feedback is essential. Without it, there's really no point, because anything that we're doing is for the patient. So we need to make sure that they're involved in communicating with us. And we need faith. We need to have faith that what we're doing is right for ourselves, right for our patients. And mostly we have to have faith that what we're doing is going to work. So back to the original question, specialist nurses, have we gone too far? I don't think so. I think we're only just getting started, and I'm excited about what the future brings for specialist nurses. So thank you.
Thank you so much, Jen. That was inspiring. Really, really good. And I think it's just thinking about, it's not just a clinical service, is it? You brought in the empathy, the consideration of patient history, etc. I remember one patient with a history of sexual abuse and really, really struggled with internal scans, and we involved our sexual health colleagues. We were out of our depth in terms of counselling, etc., just what needed to be put in place. And at the end of it, she contacted us to say that going through the actual process, being listened to and taken into consideration, all these things that from her past actually helped her cope with the future and cope with, she actually did get pregnant and helped her cope with the examinations during pregnancy. So yeah, but a lot of things that you've just mentioned there, I'm thinking of excellent ideas, and I do have a question for you later on, but I'll hand back to Robert just now. But thank you very much. Excellent.
Thank you, Val.
Yes, thank you very much, Jane. Excellent presentation. And we are now back to the Q&A session. And we have some time to ask questions among us, but I have already some questions in the Q&A session here from the participants. And the first one, which I already promised, is considering now the question of the pricing, especially with the stock companies. And so here there was a question why there are differences in the prices between using stock virtual local pharmacies, and if there is any strategy in place at the moment to try to bring prices in fertility medication more to a standard across the board, which will help to use probably more companies like the Stork company. So any answer to that?
Shall I take that one then? So I think it's important to say at the outset, and I didn't say in my presentation, Stork don't actually take any money from patients now. So we don't have full visibility. We charge the clinics, but they actually take money from patients for medicine. So we don't have full visibility of what every individual patient has paid. Thereafter, what we do, it's an opportunity for me to say that what we do charge at Stork is what we call a service fee. I get quite frustrated sometimes when I hear it called a delivery fee, because it's far more than just an Amazon delivery price. It's a private service. The NHS pays in traditional community pharmacy in the UK, but effectively you're coming for a private pharmacy service. So the fee that we charge is for all the things I've described, but the whole running of a pharmacy, having pharmacists, all the tech and the buildings and the packaging and the delivery, and it's a private service. So I think that's important to remember. And of course, there is an enhanced element because we're providing overnight nationwide delivery. Over and above that, pricing of fertility medicines, I think Kate alluded to, along with her comments earlier about pricing generally. The onus is really on the industry to be as transparent as they can about what patients will incur and when.
Well, I think there are also differences between the countries considering pricing of medication. And I'm aware, at least here in Germany, that patients cross the border to buy some medication, especially on online pharmacies, which might be cheaper than buying it in the pharmacy around the corner. And I was wondering, in UK, you are on an island actually. So do you also have these problems of border crossing and buying from different countries?
I don't believe we do as much in that regard. We pride ourselves in the UK on the controls that the MHRA and other bodies put on the medicine supply chain, and that is all done, again, as I said in my presentation, for patient safety reasons, to ensure that no medicines enter the supply chain that are anything other than in the 100% condition that they are when they leave the manufacturer, and that they've been stored and handled throughout the process the right way. And that's whether medicines are lost out of the supply chain or find their way in. We're very blessed in the UK for the controls that we have. I'm not confident that across the world everybody is quite so privileged.
Yes, I believe you are right in that point. And there is another question here from the participants. They say, considering that there are only 3 to 5% of patients who are suffering from infertility are really treated around the world, so there are millions of other patients who are not treated because they cannot afford treatment, and also there is a shortage in maybe medical specialists to provide the services. So why it is not a global situation that nurses do some parts of the treatment and make it affordable to a larger community of patients? So this is a question to all of you, actually.
I think Tim might be the best person to answer that one.
It's a very good question. I think, I mean, absolutely, as I mentioned at the beginning of my talk, I'm fully supportive of extending the nursing role. And we've just heard in the presentations earlier, all afternoon actually, about in different ways in which the nurses who've spoken have had extended roles, and there are many benefits of that in terms of patient contact, and also I think from a health economics perspective, there can also be benefits, particularly in countries where there are just fewer doctors and there are more nurses. I mean, I know there are organisations such as FIGO. So FIGO, which is a worldwide federation, International Gynecology Obstetrics, certainly has a lot of touch points around the world with trying to promote good quality care in all countries at different economic levels. Fertility, I mean, the problem is IVF is expensive, but many patients don't need IVF, and I think a lot of this also comes back to improved education and care within the community, so that perhaps people, if there's less sexually transmitted diseases, for example, in some populations, that will help reduce the proportion of people who are suffering from fertility issues, increased awareness of if there are fertility issues, going to speak to someone sooner rather than later, rather than leaving it for years and years, maybe whilst things get worse. But I'm not sure I'm the best person to answer that. But anyway, that is an answer. And I mean, saved by two hands that have gone up there as well by Helen and Val.
I think there are also some problems of regulations by the law in different countries. For example, in Germany, certain procedures will not be allowed to do by a nurse and on demand. They have to be done by a medical doctor. And I believe that there is some place there maybe to change regulations in some countries that might be even more strict with some other.
If I can just jump, sorry, that was the point. If I can just jump back on that point, actually, because again, I was, as you know, I was medical director of 3 clinics in Germany and two or three in Austria. And it was very interesting, the different expectations of what the nursing role could be or should be. And some of that came from the doctors. And so certainly in some countries, the doctors were very, I would say, I'm not saying Germany, but in some countries, the doctors were quite closed-minded, I think, to consideration. And when I told them that in the UK, as I mentioned in my talk, that embryo transfers, most ETs in the UK will be done by nurses rather than doctors. And as we heard earlier on, in some clinics, nurses are doing egg collections, Jen's doing the sedation side of things. So it's a very extended role, which is only beneficial from my perspective. But in Germany, when I worked in Germany, the nursing role was very, very limited compared to the UK. We had clinics in Denmark where the nursing role is actually quite extended. So I think some of it is, I think medically there's a bit of, we're keeping it close to us. Like maybe the doctors feel threatened by it, I don't know. I think also, to be fair, there was a patient relevance. So the German patients that I met expected that their care was done by doctors. They, for whatever reason, and I think it's historical, they just had a different view to UK patients on that nursing versus medical role.
I think if I could just come in there, I agree with that also I think there's different ways of funding treatment around Europe. And if a clinician does a procedure and it's an insurance way of funding clinics, they would get a higher fee than maybe a nurse doing a procedure. And certainly when we introduced some of the ESHRE workshops for nurses and midwives, we went to Belgrade, where nurses just are, way down the hierarchy. And it was a real battle to even get that workshop organised, because people felt that nurses were there really in that traditional role of the handmaiden. But Hilda and her team will fight the cause, I'm quite sure.
I might just come in there as well, Helen. Again, just interested in Tim, what you said, about health economics, etc. And we've just actually finished a ESHRE survey on nurses carrying out pelvic ultrasound, and the disparity between and across countries is incredible. And a lot of the reticence appears to be policy or guidance driven. So, one country might permit it and might consider it, but others, it's just a definite no. So I think, I don't know if we're ever going to change that, but I think it's just being mindful of that. But it was a good point that you made about FIGO. I actually didn't appreciate their role in all of this. So again, that's something that I've learned from this. So thank you.
If I can come with a couple of things, I'd like to mention Dr. Willem Ombelet, who has really been fighting the fight for expanding care outside of the more wealthy Western countries. There is a special interest group on socioeconomic and global aspects of fertility care within ASHRA. So there is a team that's looking at this aspect of global access, and there are people that are exploring IVF labs that are on trailers that they can move to certain areas and access regions. And there's even a group that is trying to be taken seriously about forgetting incubators and actually culturing inside a capsule that's in the vagina. So people are thinking outside the box in terms of how to get care. But I just wanted to mention a couple of those initiatives that are going on. And in terms of the roles that people have in the different borders, I think there are those of us that will not give up, that will not take no for an answer, that see that it's politics that's driving a lot of who's doing which role. And I am inherently positive in thinking that we will be able to show how it improves patient-centered care, shared decision-making, lowering costs, continuity of care. I think that the evidence, when we look at it empirically and find more and more studies and more and more people comparing and looking at the extended role, I think the science will speak for itself. So we'll get there. We'll get there. I'm positive.
I cannot find any more questions here, and
I have a few, if that's okay. I have one for each speaker, if that's okay. I'll start with
sure.
Is that okay, Tim? Since you were, I'll come back to Sue. With regards to PGTA, what is your view if you take PGTA versus cell-free DNA, so non-invasive prenatal testing, versus first trimester maternal serum screening? So if you were faced with a patient who had, say, 4 moderate grade embryos in storage and she had recurrent implantation failure, what would you be guiding her towards? I know it's difficult because you haven't got the whole history, but
Sure.
because I now do a little bit of midwifery as well, and I see patients for genetic screening.
I mean, I guess going into the reverse order, obviously, the traditional route for looking for a pregnancy affected by wrong numbers of chromosomes or whatever would be amniocentesis or CVS. And then if you're moving back into the end of the first trimester with the blood testing, I mean, that's looking for an ongoing pregnancy with a chromosomal or a genetic abnormality. So that's quite specific. And I think for that scenario of someone with recurrent implantation failure wouldn't really be relevant because the issue is further back than that. So if we then get back to embryo selection, so is it worth selecting embryos during IVF? Well, first of all, for recurrent implantation failure, I think the ESHRA document on recurrent implantation failure, and I keep on going back to it, it's very, very good, properly evidence-based, what should be done. Most of it is unknown. So actually what you should do is hardly anything. It's look at endometrial thickness and lifestyle, and that's it actually. The rest of it is all very much a grey area, including PGTA and blood clotting and all that sort of stuff is very grey. But in terms of your question, the PGTA, if that's being done, so looking for the correct number of chromosomes, may be a benefit for implantation failure. But again, the studies are just lacking. There's really nothing on that at all. But it is something that could be discussed with the patient. And I think that's then horses for courses. How many embryos are they making? Are they really good quality embryos that are failing to implant? And obviously the age of the woman, if she's older, then maybe more of a benefit. In terms of the cell-free, so that's, for those that don't know, just to make sure I'm understanding your question, that's where you're looking at the fluid around the embryo in the laboratory, and you're trying to see what the DNA is in that sort of fluid there, and
it's actually a blood test that they have done that looks at the cell-free DNA in the maternal blood.
Yeah, but that's after implantation.
Sorry.
Yes. That's after implantation, which I think by then it's a bit too late. But people have looked at doing PGTA on embryos, looking at the fluid around the embryos that the embryos are exuding, which is also sort of cell-free. It's the same name really. And there was a big Australian group that pushed that, and then there's been a massive class action lawsuit against them because what they were doing was they were saying, yes, this is normal, this is abnormal, and And I remember there was a student here in Oxford who was doing her PhD on it. And I remember asking her 6 years ago, how close is this to being available? And she said it's years away. And literally a week later, I saw it being advertised by this Australian group, but they've been hit really hard now financially because the wrong embryos were being discarded, which is a perfect example from an add-ons point of view. You should not be introducing untested things, whether that's endometrial receptivity testing or whatever it is, untested things, which just because something sounds like a good idea does not mean it is a good idea, and it might make things worse, which ERA does.
Perfect, thank you.
Well, actually, just coming back to that, even in PGTA and also looking at culture media for free DNA, there is a discrepancy of at least 15%, if not sometimes more, between the cells that you are looking around in the trophectoderm or in the media, comparing to the inner cell mass. And that's why you might discard an embryo, which is actually a normal, because you just looked at the discarded cells at the embryo. So these are usually post-mitotic failures that happened. Meiotic failures from the oocyte or from the sperm will be present in all the cells. And for example, in my center, well, this is just because in Germany, we are not allowed to do PGTA on the trophectoderm. We use PGTA on the polar body. And the indication is really advanced maternal age. And there you really find the post-meiotic before and after fertilization. And this will stay with the embryo. They cannot be corrected. So for this patient, you can reduce the time to reach a pregnancy by avoiding using embryos, which will be definitely not normal, because this is now 100% will stay not normal. So you are not discarding normal embryos. And if you have a patient who is 41 years old and have 5 embryos, 5 blastocysts, and they are all abnormal, you will use usually 1 year until you transfer all of them to find out that she is not pregnant, or she might have even a miscarriage. And with 42, the probability to find the euploid embryo will be even lower. So we are not looking at the live birth rate per started cycle, but we look at the time to reach a pregnancy, ongoing pregnancy that we deliver. And I think in some of the studies, the target, why you are using something, is not correctly put in place. And then you are just mistakenly say that something is not working, but not because it's not working, but because the target was not really correctly set.
Okay.
So this is one of the problems. And I experienced now ART for more than 42 years. And during this time, there were a lot of fashions coming and going, and a lot of things happening, but mostly things that, as Tim said, started implemented before even looking if it's working, or used for wrong indication, or when analyzing it, just put the wrong question, is it helpful or not? So I think infertility is a very complex problem, and it cannot always be solved by very simple things. So we had to look at the whole thing as a complex, and the patient that we see in the clinic is not the patient that we look at the RCT. They are selected patients, and they have other situations because a lot of things are excluded. So in the clinic, you will have patients with more complex situation. And then it's important to make decision for the certain patient, what kind of treatment or what kind of examination or diagnostic I need to do for this patient in order to help her to reach the pregnancy. And that's why I think it's very important.
Thank you. I'm all right to ask Jen a question now. So is that okay? Have I got time for that?
Yes,
I'll be quick. I'll be quick.
Yeah.
I was really encouraged to read about or hear about your red sticker initiative, Jen. I think that is an excellent idea. What has been the interest? Uptake's probably not the right word, but how successful has that initiative been?
We haven't had many red stickers handed over, but we have had a lot more patients make appointments with the sedation team to discuss their treatment without divulging any information. So I think the openness of making our patient group aware of the fact that we are trauma informed and that we have an awareness that patients have difficulty without there being divulging of information, and without the use of the red sticker, we have definitely seen an increase in patients who want to have an appointment to discuss their treatment and discuss difficulties that they have. So this is becoming much more regular, and the work that we were doing with our counsellor, there's definitely a two-way flow of patients that we identified that may have difficulty that we're referring into our counsellor, but also patients that our counsellors identifying that may have difficulty with the patient's permission. We're making contact with them to organise to meet with them to discuss their treatment, especially with the increase in our fertility preservation for transgender patients. We've seen a big improvement in their ability to cope with their treatments, with coming through for sedation and having the red collections done. With us being able to meet with them beforehand and discuss how they would like their treatment to be. Considering we were started for procedural anaesthesia, I'm pretty pleased with the fact that we're managing to look at a more holistic approach to providing sedation for our patient group.
So if anything, your stickers have obviously highlighted the fact that there is a safe space to talk about these issues. Yeah. So I think it's an excellent idea. So thank you for sharing that. That's great. Thanks. I think that's about us, isn't it? Robert, are you going to mention the...
Yes, well, I think we covered and now also in the Q&A some of the important aspects, and also through the afternoon we went through, I think, very important aspects of the role of the nurse in the treatment, in the ART treatment. And I think it's the best time now to hand it over to you, Helen, and Valerie, to summarize and conclude our afternoon meeting.
Thanks so much, Robert. Well, as you say, it's been a fascinating afternoon. And as Tim alluded to, the fact that we're all sitting in our clinics or our studies or our front rooms or wherever it is and haven't now got to leap on airplanes to get home late at night is just so amazing. I hope the delegates have enjoyed this afternoon's contributions, which have been really stimulating. I'd like to thank Robert and Val as co-chairs, and Val, Hilda and Kate for the first session. Sue, Tim and Jenny, thank you very much indeed for your contributions this afternoon. And we need to thank Chloe and the IT team, because without the IT team, I think we'd have all been having nervous breakdowns. I understand that you'll, as delegates, be sent a questionnaire to complete, and hopefully you completed the questionnaire prior to the talks and you will now do them post, and then that gives us an indication of how much you have learned this afternoon. You will receive a certification of attendance, which you can use for CPD points and for your portfolios. And I understand that this whole webinar is available online for people to access afterwards. This is the what we can see, the accreditation from the bodies that have given us accreditation. And I think basically we've had a good afternoon, and I would really hope that you've all enjoyed it and that you have a great weekend, those of you that aren't working. So thank you very much for your time and your attendance.
Thank you, Helen.
Thanks for having us.
Thank you.
Pleasure.
Thank you.